Come on now. Okay, technology. So if we think back to chapter 8, and we're talking about anatomy and physiology, all right, we talked about the fact that the body has to get adequate perfusion in order to function appropriately, okay? And we all remember what perfusion is, right? The delivery of oxygen, glucose, other nutrients to the cells so that they can function appropriately, right? They can get the energy they need, they can continue to do their job, right? If we don't, then things go bad, right? So shock, all right, is basically a state of inadequate perfusion, meaning the cells are not getting the oxygen, nutrients, and things that they need in order to function, okay? So what happens then is shock, the cells don't get what they need, the cells die, the organs die, and eventually then we die, right? It's kind of that little cascade, all right? So what we see when somebody's in shock, all right, so our signs and our symptoms, the things we're able to assess for in our patient are a result of our body's attempts to then restore back to that homeostasis or the way things are supposed to be, right? It wants to try and restore perfusion so everything can work well, all right? Resuscitation then is the emergency care provided to try and restore bodily functions. Like I said, we're talking kind of two different categories here. So resuscitation is when the body functions have ceased and we now need to take over and try and get things restarted, all right? So we mentioned that already, that shock is inadequate tissue perfusion or hypoperfusion, okay? So if perfusion is getting oxygen and nutrients to the cells, then hypo means we're not getting enough, right? We break down our medical terminology there. Basically, not only are we not getting what we need to the cells, all right, but we're switching from that anaerobic, or excuse me, the aerobic to anaerobic metabolism. So we're getting increased amounts of waste products, okay? Even while we're still in aerobic, we're not getting good perfusion, we're not getting rid of the waste products, right? So we're not getting what we need in, things are starting to not function properly, and in addition to that, then all the wastes are starting to build up. So we're starting to cause a little bit of a crisis situation within ourselves, all right? As we switch from aerobic to anaerobic, all right, our production of ATP falls. Therefore, we need ATP to move sodium and potassium through the pump, right? We all remember potassium enters from the outside, ATP jumps on, activates the pump, and we move sodium then back out of the cell, all right? If that pump stops working, sodium stays in the cell. What likes to move in with sodium? Water. So eventually the cell will swell, rupture, and die, all right? And then as the cells die, the organs die, and we die. All right. So the treatment for shock is aimed at restoring the perfusion, all right, so we can get the oxygen and nutrients back to the cells we need, okay? If you think back to chapter 8, there was a nice long list of components that basically kind of drove the slide presentation, right? We went through from top to bottom, from adequate oxygen in the ambient air. We had to have the mechanics of ventilation to get the oxygen in and out. We had to have the gas exchange take place in the lungs, right? Remember that whole big long process that gets us to adequate perfusion, all right? So when we're thinking about how we're going to treat somebody who's in shock, all right, we have to have those things in the back of our mind, right, that list, and then assess our patient for what is keeping that list from being completed, all right? If they've got a tension pneumothorax, well, then our mechanics are not working right. Our gas exchange may not be working right, okay? So we've got to do what we can and try and intervene in that process somewhere to try and get that chain going again. Does that make sense? Some of the most important ones, all right, are going to be breathing in an adequate amount of oxygen. How can we change that? If our patient isn't breathing in enough oxygen, how can we change that? We can give them some, right? We can throw an honorary breather on them. We can bag valve mask. We can even nasal cannula, right? I mean, a little bit of oxygen through the nasal cannula. But if we really want to make some drastic changes, we can slap an honorary breather on them or use a bag valve mask with high flow O2, okay? So we think about where the things are going wrong and how we can then fix them, all right? Diffusion of oxygen from the alveoli into pulmonary capillaries, all right, is a big thing as well. We can kind of intervene by doing positive pressure ventilation, kind of try and shift our pressure gradients if there's problems there. Oxygen transport to the cellular level, maintaining blood pressure, all right, and that kind of thing, stopping bleeding. Those types of interventions can help that. all right? And then the release of oxygen at the cellular level, and a whole heck of a lot we can do there. But those are some of the most important critical features of getting our oxygen delivery, all right? So when we're thinking about shock, all right, we have three different parts to the puzzle that have to equal perfusion, okay? So when we look at shock, that means one of the three is broken, all right? If you think about the movement of water, the movement of liquid, which is ultimately what we have to do, we got to get the blood to the end game, right? We can get the oxygen in and out as much as we want, but if we don't have something to circulate it and deliver it, it's not going to go anywhere or do anything, all right? So we have to have adequate blood volume, okay? An adequate pump function. What's our pump? Heart. Good. And then adequate vessel tone, okay? So we have to have a pump, some pipes, and some fluid all working at the same time together to get delivery of that water through, okay? So when you're looking at shock and trying to figure out what's going on in your patient or what type of shock they have, we look at those three things and we try and identify, is this a pump, a pipe, or a volume problem, all right? And then that kind of points us in a direction of where our treatments can go, all right? So when we have a volume problem, okay, it's pretty simple. We have some form of decreased blood volume, all right? And when the volume goes down, we then decrease preload. Oh my goodness, you're talking a lot about chapter 8 today. Everybody's starting to have a seizure, right? So we decrease our preload, which is what? The amount of blood before the contraction, right? Everybody remember Starling's law, right? The rubber band theory. The farther we pull the rubber band, the farther it'll shoot. The more we stretch before the contraction, the harder it's going to contract and shoot blood. Good, so that's our preload. So if we take our preload down, what happens to that, to what comes out? We get decreased blood, right? So if our preload goes down, then our volume and our cardiac output fall, which then causes what else to fall? If you want to cheat, it's the third bullet point. Blood pressure, right? So if our systolic blood pressure then falls, right, we can't get blood all the way to the end of the system, so then what happens? We get poor tissue perfusion, right? So it's this nice little cascade of things based off of the fact that we just lost too much volume. The pump is still working great. The pipes are still doing what they need to do. We just don't have enough fluid to make the system work. All right? Sound good? So how do we get inadequate volume? All right? It can come from either a loss of whole blood, all right, or from plasma volume. We'll go into those in a little bit more depth when we talk about hemorrhagic shock specifically in just a few minutes, all right? So, but those two can result from either bleeding, vomiting, diarrhea, excessive urination, or increased capillary leakage, all right? Lots of different ways we can either lose the plasma or the entire blood, all right? Basically what then happens to this patient is we need to somehow increase their blood volume. At the basic level, we don't have a whole lot to do that with, all right? At the ALS level, we can kind of try and supplement it with saline and IV fluids, that kind of thing. But there's some positives and negatives to doing that, all right? So at the EMT level, this is where our supine comes in, right? We want to make sure we stop the bleeding so the problem doesn't get worse, all right? And then we lay them supine so that they have the highest blood pressure possible, and we get them to the hospital where they can give them blood, that kind of thing. Does that make sense? All right. One thing we need to remember, all right, is that if we have a whole blood loss, we're not only losing the volume, but we're losing our red blood cells. And why is that a problem for us? That's where oxygen gets carried, right? So that's kind of one of the downsides to trying to throw IV fluids back into somebody, all right? If they, for us on the ALS level, if they've lost a whole lot of blood because they're bleeding out and we throw fluid in them, okay, IV fluid's only going to go so far. Sure, we're going to raise the blood pressure, but what doesn't IV fluid contain? Red blood cells and oxygen carrying capabilities. So our oxygen carrying capability is still going to be low, right? We're going to make our patient at least a little bit better by throwing that fluid in them and circulating what red blood cells we got left, all right? But if we can't replace the red blood cells, we're not going to do much for our oxygen carrying capabilities. So ultimately, we need to get somewhere where there's blood, okay? Questions on volume? All right, so next is going to be our pump, okay? Our pump is our heart. So if our heart fails, okay, regardless of our blood volume or our vessel size, all right, if you don't have something to physically move the blood, nothing's going to happen, All right, we're not going to get the oxygen, we're not going to get the blood. Pretty simple process there, yes? All right. So how do we get inadequate pump function? Okay, this can occur from myocardial infarction. What is myocardial infarction? What does everybody else know it as? Heart attack, right? So we have a myocardial infarction. We kill off a bunch of our heart muscle tissue. All right. Unfortunately, we can reperfuse it, right, up to a certain point, and then after that, once it's dead, it's dead. We haven't figured out how to regrow it yet. All right. So that tissue is now dead. All right. You get a massive heart attack, and let's say your left anterior descending, right? We call it the widowmaker because it kills a lot of people when it gets occluded, all right? It's the main blood flow feed to our left ventricle, which is by far the most important one in our heart, all right? And let's say it kills off about 50% of that ventricle, and so now our heart is only pumping at about a 50% rate, okay? As we continue to have problems, all right, further heart attacks, get older, the muscle tissue that's good starts failing, then we're going to start to go into a form of shock, right? Because we can't pump as adequately as we need to, all right? We can just have regular old heart failure, okay, which we'll talk about more when we get to the cardiac chapter, but basically for whatever reason, whether it's myocardial infarction, a long time of untreated high blood pressure, or just flat out old age, your heart muscle starts to give out at a certain point, right? So we get heart failure, or by some sort of mechanical obstruction to blood flow, all right? When we talk about trauma, which is what we're talking about currently, all right, typically that's where we get pump problems, is from that obstruction of the blood flow, okay? Cardiac tamponade, tension pneumothorax, those kind of things, all right? We'll talk about those more in depth when we get to the chest trauma, okay? In a lot of these cases, all right, we start to see heart failure, so we see a drop in our blood pressure, okay? And we have the assumption is, oh my gosh, the blood pressure is low, we just got to throw fluid out, okay? In this case, we're not having a fluid problem, so we can actually start to make this worse, all right? So you can see where a good solid physical assessment, not that you guys are getting fluids at the EMT level, but a good solid physical assessment as to why we're doing or having our problem, right? And identifying pump, pipes, or fluid is kind of key, because if we misidentify somebody in heart failure as a fluid problem, we can actually start to make their problem worse by giving them fluid. Does that make sense? Okay. Questions on pump function?
Sometimes you have a combination of all three or two.
Sometimes you get all three, absolutely. Yes, it's not always just one or the other, all right? And we'll see when we start talking about some of the very specific forms of shock, all right? So we kind of end up with this little bit of a tree, if you will, all right, or a flow chart. We've got shock up here at the top, all right, in this big general category, all right? And then we have what we call our etiologies, right, or our category, what causes shock, and we'll talk about our categories, all right? And then we'll have our specific types down here, right? And we kind of branch out. So we'll get the different categories of shock coming up here, and then each category is going to have a couple of different types of shock. Does that make sense? And when we get down here to the bottom, sometimes we're exhibiting a little bit of both, all right? So yes, that is absolutely correct, that we don't always get just one. So vessel tone, so this is our pipes, okay? We talked about the pump, talked about the fluid, now we gotta have the pipes right, okay? So if we're looking at just this picture here, all right, so what our body is able to do is either dilate and constrict blood vessels, all right, to help kind of regulate the pressure within them, all right? Where's my fire guys? Raise your hands. Who's been through a fire class before, right? Or have a little bit of it, right? Okay. So you got a little bit of idea how to pump the truck, right? All right, picture on the left, 1-inch diameter brush line. You send 150 PSI through it. What's it gonna look like at the other end? Yeah, you're gonna have a whole lot of pressure, not a whole lot of pressure. You're gonna have a whole lot of pressure, right? So you send that same 150 PSI through a 5-inch large diameter. What are you gonna see at the other end? Going to dribble out, right? Same thing with your vessels, okay? If I push the same amount of blood with the same amount of force, because the volume's good and the pump's working, through this vessel that's of a appropriate size, it's full, I've got plenty of pressure, and I've got enough pressure to make it to the end of the hose, right? Okay? Which is, the end of the hose is our cells, and we get perfusion. if something happens and our body can't hold tone anymore and those vessels all dilate and become very big, the heart's going to stay the same. It's still pumping just as hard. And the fluid's still the same. Now we're in a really big, giant container, and we're just barely dribbling out the end, meaning we're not getting perfusion to the cells. Does that make sense? All right, so that's where our pipes come into play. All right. So, massive vasodilation typically occurs from loss of sympathetic nervous system function, right, or chemicals within the body. All right. So our nervous system has lost its ability to communicate, all right? The sympathetic system has gotten knocked out by some sort of injury or interruption in the communication pathways, and now our body is just like, all right, cool, and everything just relaxes, gets big, all right, and doesn't function. We can't hold tone. So the brain could be getting the message all day long, hey, blood pressure's not good, perfusion's not good, we need you to diet or constrict down, right? But because of the interruption in nervous system function, we're not getting that message, and those vessels are staying very big. And now we've got a hypoperfused system because we've got a low blood pressure. All right. We can also get it from chemical mediators, right? We see this one. We'll talk about it a little bit more specifically, both here, and it's got its own chapter when we talk about allergic reactions and anaphylactic shock. All right. So treatment includes vasoconstriction and volume restoration. Okay, so we're going to kind of hit this one from both ends. All right, for you guys, right, lay them supine, try and get the blood pressure up. All right, if we're talking anaphylaxis, anybody know what medicine we got in our box? Epinephrine, right? It's a wonderful vasoconstrictor, right? We've got some better ones on the ALS side, but for the BLS side, it works pretty good. Okay, so we're going to get them supine. We're going to get them some oxygen. We're going to give them some epinephrine to try and reconstrict. All right, and the reason they talk about volume restoration a lot in these slide presentations is because in certain states, IV skills are an EMT thing, right? So you could do some volume as an EMT. All right, so we need to get the vessels back to where they were, okay? And if we can't, or in the interim, we're going to start dumping fluid in to try and fill the bigger container. Does that make sense? We got to be a little careful because then when we start constricting down, we're going to have to cut the fluid down so that we kind of match fluid for pipes, but ultimately, we need more volume and a smaller container. Make sense? So treatment for shock, okay? Depends on the underlying cause. So we're going to go through categories and specifics, all right? And depending on what it is that's causing our problem, right? Whether it's pump, pipe, fluids, et cetera, we're then going to treat, all right? We always want to consider requesting ALS, but we need to weigh the benefit versus a delay in reaching the hospital. Again, you're 5 minutes from the hospital, 10 minutes from ALS, right? Guess what? The hospital provides ALS. Get them to the hospital, okay? Whatever your closest ALS is, consider the hospital as an ALS option, all right? For a lot of these, as ALS providers, we bring some things to the table, but not enough to make it worth the delay, okay? So make sure you're treating this patient like you would most other trauma patients, right? Somebody in shock is a critical trauma patient. We get off scene as fast as we can. If we can get ALS either to the scene or meet them en route, something like that, then yippee-doo-dah. If not, the hospital will work just fine. They can do everything we can do and more. Okay? Sound good? So, categories of shock. All right? So this is where we need to start doing some very serious concentration and memorization, because the categories of shock, the specific etiologies or specific types of shock, those kind of things, this is where a lot of your assessment abilities, you're going to need to be able to pick these out in a patient. You're also going to need to be able to answer test questions about them, okay? So you'll notice we've got 5 different categories of shock, all right? Most commonly recognized are 4. The book kind of throws the 5th one in. Some people recognize it as a category of shock. Some people not so much, right? But the big 4, right, that I would absolutely 100% commit to memory, because we're going to ask you about them, all right? Again, the 5th one, we're going to tell you about it. Remember what you can. Not always standardly recognized as a type of shock, all right?
It's more of an outcome, I think.
Yeah. It kind of fits into shock because in a way it's the interruption of perfusion, but you'll see where it differs pretty heavily, right? You'll see exactly what we're talking about here in just a minute. So our big 4, all right, are cardiogenic, hypovolemic, distributive, and obstructive. Okay, if you didn't write all 4 down, don't worry. Guess what? There's slides on all of them. Okay, so hypovolemic shock is our first one. Okay, so break the word down. Hypo meaning what? low, volume, emic, blood. Hey, what do you know? Okay. So hypovolemic shock is caused by low blood volume. Okay. Hemorrhagic is the most common cause of hypovolemic shock. Okay, but it can also be caused by burns and dehydration. Okay. So hypovolemic, remember I said we're going to get this big category and then there's going to be some specific types underneath it, all right? So hemorrhagic shock can result from either whole blood loss, meaning we have an opening in the vessel, okay, where the entire blood, everything that is in the blood, the plasma, the platelets, everything, the whole kit and caboodle is leaking from the system, okay? We're losing our red blood cells, our white blood cells, our platelets, everything, plasma. It's all going out the window, okay? Plasma or non-hemorrhagic hypovolemia, all right, is things like nausea, vomiting, diarrhea, okay? We can start to look into some of our other forms. We'll talk about sepsis later on, okay? So this is where we are just losing the plasma or the liquid, right? We've been vomiting our toenails for the last 3 days because we've got a really big GI bug, right? Some sort of a virus that gets passed around, right? Kids brought it home from school, yay school. And we're just losing, because we're getting rid of so much of our fluid, all right? It's starting to go from high concentration to low, so it's leaving the cells to help hydrate those other areas of the body because we've been vomiting and diarrhea so much, okay? So now we've got a low blood volume because we've lost the plasma. We still got all the stuff floating. It's just getting a little sludgy in there because there's not enough hydration to move it around very well. Make sense? Yeah, you did better. All right. So distributive shock, all right, is caused by vasodilation leading to a relative reduction in our intravascular volume. Okay, so is this pump, pipe, or fluids here, you think? Pipe. So that part of it is pipe, right? So we've got a big pipe. We don't have we have the same amount of fluid, so we get hypotension and we get some interruption in our perfusion. Okay, so distributive shock, we've got an interruption in the distribution then via the pipes, right, or the vessels of the blood and oxygen and nutrients. Okay, this can also involve some fluid loss from increased capillary permeability. All right, so this is where we're starting to get into a little bit of both. Okay. We get that vessel nice and big, that wall gets nice and thin, we can start to kind of leak some fluid out. All right, so we can.
Or some sort of blistering?
In a way, yes. In a way.
First spacing.
Yeah.
An interstitial space?
Yep, sending it out into the space outside the vessel. So. Cardiogenic shock, all right, is caused by inability of the heart to contract effectively. All right. Generally occurs with a loss of about 40% or greater of the left ventricular volume, all right? So earlier I mentioned we have a heart attack, we lose 50%. We're probably going to start to see some signs of cardiogenic shock until we can kind of rearrange the system a little bit to hopefully account for that, all right? Stroke volume and cardiac output are then reduced, meaning then our blood pressure is reduced and then our perfusion is reduced, all right? Obstructive shock, okay, is just that. Something is obstructing, all right, our forward blood flow. All right, obstructive shock causes include pulmonary embolism, tension pneumothorax, and pericardial tamponade. Our treatment is then aimed at trying to relieve said obstruction, okay? So if we look at these causes, all right, a pulmonary embolism, all right, is a blood clot in our pulmonary vasculature that decreases the ability of blood to flow to a specific area of our lung, okay? If blood doesn't get to the area of the lung, then we can't pick up oxygen, we don't do any transfer, and we start to decrease the amount of oxygen circulating in our bloodstream, which then in turn decreases our perfusion, right? Okay, so we've got an obstruction in that vessel and our body's ability to get oxygen into the system and then deliver it to the cells, okay? Tension pneumothorax, all right, there in the middle. This is when we start to have our collapsed lung, right? We've talked about the tension pneumothorax, a smidge. We'll cover it some more in chest trauma, right? But we've got a hole in the system, right, in that closed system that is our thoracic cavity, So air is not only coming in the trachea when we expand and make negative pressure, but it's also coming in that hole. It gets in between the two linings and it starts to collapse down the lung, okay? If we don't treat it, right, just the collapsing of the lung is what's called a pneumothorax. If we don't treat it early enough and everything starts to shift, right, so as this pressure starts to build up, all right, you'll notice that that lung starts to shift against and try and go to the other side of the chest. Well, there's some fairly important things in the middle, right? Okay, i.e. your heart. And as your heart starts to get pressed against, all right, the space it has to expand and contract and be able to beat and pump blood starts to become smaller and smaller, and therefore it doesn't have very much expansion, therefore it doesn't have very much contraction. Nothing comes out the other end, and voila, we've got hypoperfusion, right? On top of the fact that we're only operating off of the one lung, right? So our oxygenation is now down, and we've got a little bit of a double whammy. Yes? Yes, ma'am.
That kind of set up a heart attack as well. Like if you're like losing the rhythm.
It's not going to necessarily set off a heart attack in the sense of where we got a blockage to the vessel, right? But we're going to decrease our coronary oxygen supply because we're decreasing the overall supply, right? So the coronary arteries are not going to be getting as much oxygen, not to the point that they are when we're talking about myocardial infarction, or at least not until the very, very, very end, right? Ultimately, if we let this go unchecked, yes, we will cut off enough blood flow. There will be not enough oxygen, and the heart muscle will start to die as a whole, but not as specifically as a myocardial infarction. Make sense? Pericardial tamponade, all right, is another form of obstructive, all right, or something that can cause obstructive. If you'll notice in the picture here, we've got some blood that's starting to fill up, okay? So this is where we have some sort of either a contusion to the heart from blunt force trauma, or maybe we nicked it on the way by, all right? But we have bleeding of the heart muscle tissue, okay, into the pericardium, which is the sac that surrounds the heart, okay? And so that sac can only stretch so far, and once it continues to bleed, then the pressure starts to collapse down, and we get kind of the same thing as we did in the tension pneumothorax, but it's just isolated to the heart itself, whereas the heart can't expand and contract, so it stops beating, or it doesn't necessarily stop, but it can't beat as well, and it stops sending blood flow down the line. Does that make sense? Yes, ma'am.
So how do we know what type of shock is patient going through, since they all lead to poor perfusion?
They all lead to poor perfusion. So we look at mechanism, our physical assessment, those kind of things, okay? So our tension pneumothorax guy, right, if he's showing signs and symptoms, he's gonna have some form of, like a flail chest, a sucking chest wound, some form of blunt force or penetrating trauma to his chest. And then when we talk about the compensated, decompensated, all that kind of stuff here in just a little bit, we'll look at his vital signs, that kind of thing, all right? We're probably not going to be able to all the time tell 100%, yes, this is it, all right? But if we put together an assessment, some vital signs, mechanism, you know, all that kind of stuff, we should be able to get pretty close to it, all right? There's, you know, pericardial tamponade, a little hard to diagnose in the field unless you really kind of know what you're listening for. You've got the right environment to be able to listen to heart sounds and put all the vital signs together, that kind of thing. But you're going to be able to get close. You're going to be like, all right, we've had blunt force trauma to the chest, we've got signs of shock. Chances are we've got boom, boom, and boom, right? We got our little list. We run with it and go from there. All right. At the basic level, treatments stay pretty much the same across the board. All right. So, you know, if you've got a list of 3 and you're like, I think it could be this, this, or this, cool. Right? Supine oxygen, transport, stop bleeding, cover sucking chest wounds, all those type of things, right? When you get to the more advanced levels, we work a little bit more off the differentials. We got a little bit more interventions we can provide, a little bit more in terms of assessment techniques and tools and that kind of thing. And we can narrow it down a smidge more. But in some cases, we're not going to get the exact one, cool, right? So, sound good? All right. Did I see another hand?
It's fine.
Okay.
I got it.
All right, so this is the 5th one, all right? This is the one that, like I said, it's not super commonly recognized as a type of shock, all right? And I believe the book even kind of admits to that one. They're like, we throw this one in there, but it's not always the most recognized, right? And this is either metabolic or what they call respiratory shock, which is a dysfunction in the ability of oxygen to diffuse into the blood, be carried by hemoglobin, offload at the cell, or be effectively used by the cell, all right? So these things can be like carbon monoxide, cyanide poisonings, that kind of stuff, where carbon monoxide, all right, has a greater affinity for the hemoglobin site than oxygen by about 250 times, right? Once that carbon monoxide binds to the hemoglobin, your oxygen can't, so your body doesn't have the ability to transport oxygen. So you get, technically, you then end up with poor perfusion, which is why they throw this in here, all right? Cyanide, right? It makes it so the body doesn't, the cells don't recognize oxygen, they don't pull it from the bloodstream, don't use it well. So eventually, yes, you end up with poor perfusion because you don't get the oxygen even though the systems are all working right to get it there. Does that make sense? All right. So this is kind of I'm not a big fan of it, but it's there. All right. If you gotta go, go. All right. So what are our 4.5, maybe 5 categories of shock that we just talked about? Give them to me. Hypovolemia.
Cardiogenic.
Cardio.
Obstructive.
Okay. Distributive. Cool. All right. So we're starting to build our shock tree here, yes? All right. Cool. So hemorrhagic hypovolemic shock. So now we're talking about some specific types of our different categories, right? So we're bringing the categories down and getting real specific on the types of shock that we've got there, okay? So hemorrhagic hypovolemic shock occurs when we get the loss of whole blood from either medical or traumatic causes, okay? So the vessel has opened, blood is leaving the system as a whole, okay? So not only are we losing our volume, but we're also losing our ability to carry oxygen through our red blood cells, okay? And with combination of both, we're getting poor perfusion, okay? Our treatments and our focus here, right? Stop the bleeding, all right? This is why we look for hemorrhage in a lot of different places, okay? Because whole blood loss can start to cause us problems in a very big hurry, all right? We can also have what's called non-hemorrhagic hypovolemic shock, all right? And this is a loss of fluid without the loss of the red blood cells, okay? Like we said, vomiting, diarrhea, sweating, okay? In this case, administration of IV fluids can be very, very, very helpful because we still got all the red blood cells and all the oxygen carrying we need. We just got to put the plasma back, so the saline works wonderfully to help fix these patients, okay? It makes a nice stopgap in the hemorrhagic patients, right? But if I don't plug the hole, I can put as much saline as I want in the other end, right? But if it's coming out wherever it's coming out, by the time I get to, eventually I'm going to get to nothing but saline, and saline can't do what? Carry oxygen. So I'm going to have a wonderful blood pressure, but my SpO2 is going to be in the tank, and my patient's going to be hypoxic and die because there's no oxygen running around with that wonderful blood pressure of saline, okay? So plugging holes becomes the most important thing in the hemorrhagic. Okay, in the non-hemorrhagic, we can give IV fluids, we can make a nice turnaround, everything goes back, gets to be kind of hunky-dory, we figure out why, we fix, that kind of thing, all right? So non-hemorrhagic, okay, like we said, going to be our vomiting, diarrhea, sweating, right? So when we get, it's the time of year for sweating, right? Okay, early summer, we start to see a lot of people go down because they're not acclimated yet. They overdo it, that kind of thing. They go out and they sweat too much, and they get this non-hemorrhagic hypovolemia because they just got rid of too much of the plasma. Questions on those two? Cool. So another type of hypovolemic shock is going to be burn shock, okay? The plasma and plasma proteins leak from damaged capillaries, okay? Loss of blood and plasma oncotic pressure leads to edema, all right? So what we end up with is, as we get our burn injury, okay, and we'll talk specifically about those down the road just a little bit, all right, because there's a chapter on burns, but we get damaged tissue, and with damaged tissue, we get damaged capillaries, all right? And so although we don't have, in some cases, we don't have enough damage to let whole blood loss out, okay? We've got enough damage that the plasma starts to leak through those capillary beds because we've got some damage to that really thin wall. So the fluid can come out, but the larger things like the red blood cells, the white blood cells, the platelets can't pass through that permeability of the vessel wall, and so they stay behind. All right. Ultimately, we get a buildup of fluid. All right. We get a buildup of a loss of the oncotic pressure within our vessels. All right, and we start to get swelling and edema, and we get all puffed up after the injury because all of our fluid is leaking out. Okay.
Do you carry albumin on the ALS?
Some of the critical cares, maybe some of the flight programs do, but we don't know. Typically, there are a lot of great things that we could carry. A lot of the reasons we don't, one is cost, two, some of the things, and I don't know enough about albumin to know if they fall into any of these categories. Refrigeration tends to be a challenge. And then two is just our limited time with the patient. You know what I mean? Like, especially here, you know, in Central Texas, I can't swing a dead cat in this area and not hit a hospital of some sort. You know what I mean? So that's why a lot of those things go a little bit more towards the flight programs, like they're talking about one of the hot button ones is TXA, I can't say the full word, but it's the T something acid, right? It's a clotting thing. A lot of the flight programs are starting to carry, a lot of the flight programs carry blood, right? They don't do nearly the number of calls. So to, you know, keep blood in a refrigerator, move it to a cooler and take it with them, you know, the 3 times a day they maybe fly, not such a big deal. Whereas with us, we spend 12 hours out of our station in our truck to try and refrigerate blood. And
Stop taking blood.
I'm not sure if they still do or not. I know at one point they did. Did they stop? So, and a lot of it just comes into the benefit and the amount of time we have them just isn't strong enough to warrant going through the hassles of having them. So some of the ground, like if you work the ground system where you're way out and you've got really long transport times, you see those folks tend to carry a little bit more of that stuff because they have a longer period of time with their patients. So, all right. So anaphylactic shock, okay? Anaphylactic shock, all right, is where we get chemical substances released as part of our reaction. And we'll talk more about that when we hit the anaphylaxis chapter, which causes massive systemic vasodilation and capillary permeability. So we're going to get a little bit of both here, right? So we're kind of transitioning from we're going to switch these here. Actually, we're going to leave that one there. We're kind of transitioning from hypovolemic into distributive, okay? So our anaphylaxis can kind of sit a little bit in the middle here because we're going to get a big vasodilation, right? So we're going to have a pipe problem, which is what type of shock? Distributive, right? And then we're going to have an increased capillary permeability, which is going to cause us to leak plasma, which is hypovolemia. More specific, non-hemorrhagic hypovolemia. Good. All right, cool. So you'll notice that these kind of carry over and carry a little bit of both. All right. Epinephrine is our medicine of choice because it gives us some nice, good vasoconstriction, right? It basically gives our sympathetic nervous system a boost. All right. We just kind of jam on the gas pedal. All right. So that's in your box. You carry it. So for anaphylactic shock, epinephrine is your choice. All right. We give it as the ALS level for lots of different things. You give it just for anaphylactic shock. So septic shock, all right. Bacteria and toxins in the blood lead to vasodilation and an increased capillary permeability. So here's another one that's kind of running a little bit of both, all right. Basically, this person has had an infection that either got very quickly, very severe, or they kind of ignored it over time. It went unchecked, that kind of thing, and it got severe enough to where they are now causing vasodilation, all right, and then the increased capillary permeability. This patient can benefit from ALS treatments, all right? Again, kind of our standard rules apply, evaluate the seriousness of your patient versus the ability to get ALS there and the ability to get them to the hospital, all right? Sepsis is one of those things that's kind of taking a front seat right now in terms of recognition, so like early recognition of sepsis and getting them to the hospital. They started doing some studies on the morbidity and mortality of somebody with sepsis, and they found that if they don't get like antibiotics, broad-spectrum antibiotics, and a liter of fluid within the first hour of arrival at the ED, their morbidity and mortality goes to like 50% or something like that. It's kind of like a thought. We're going to flip a coin and see whether this person lives or not. So we're working towards kind of an alert type program, right? We have trauma alerts, stroke alerts, STEMI alerts, those kind of things, where when we call them in the field, they cause a cascade of spin up at the hospital so that they're ready. They can intervene in a real big hurry. What it's going to look like on the hospital end, probably not nearly the spin up and the severity of the other three that we have, but we are going to like a sepsis alert type protocol where we basically tell the hospital we've got a really high index of suspicion that this person is septic. So that way it kind of puts them in the mindset of, and there will be some procedures that go on their end. So as soon as we walk through the door, they can get that process started and hopefully get the antibiotics and the fluid on board within the amount of time. So.
Texas Children's do that.
What's that?
Texas Children's used to page us out the septic shock.
Yeah. Ours is gonna include, we've got, and we did training on it a while back, so I'm gonna have to go through and review it before it rolls live in July, I think, or they may have pushed it back. So we've got specific signs, symptoms, fever, and then we're actually gonna be carrying portable lactate monitors on our ambulances, and if it's over 4, then it's sepsis alert. The monitors are actually the thing that's holding it up right now, because this is where the United States gets really fun to deal with, right? There is no either FDA or whoever approves monitors, right? Whatever governing body in the federal government. There is none approved, portable ones approved for use here in the United States. Been using them in Canada, Europe, all that kind of stuff for years and years and years and years. But we don't have any approved here in the United States. So we had to actually go to get them on the trucks and go through this big like override process through the federal government and blah, blah, blah. And we had to get somebody from another country where they're approved for use to sign off on paperwork and protocol and everything like that says, yes, we think this would be a good idea and an appropriate use. And it's this giant hoopla that we've had to go through. And so we ran into a couple of snags there. And so it's delayed us a little bit, but they're coming. Let's see. So neurogenic shock, all right? Neuro meaning nerves, nervous system, right? Okay, so here we're gonna have some sort of nervous system impairment that's gonna cause us to have some shock symptoms, right? So the spinal cord injury can cause a loss of sympathetic nerve fiber functions, all right? We're responsible for maintaining blood vessel tone, okay? We lose tone, we lose systemic vascular resistance, we get a really big container, and we lose our blood pressure, which then we lose perfusion, okay? So where does neurogenic shock sit in our categories? Distributive. Distributive. It is 100%. It's all distributive, right? We started in hypovolemic. We covered a few that kind of went both ways. Now we're 100%. This is a distributive shock problem. All the fluid is where it's supposed to be and not going anywhere. The heart is pumping great. We just got too big of a vessel because we injured our nervous system and we can't do anything. Okay? So, cardiogenic shock. Which one do you think that one fits into? So, I think we actually have a duplicate slide there. We covered that one already, didn't we?
In the sense of the book, it's both a category and a type of shock.
So category and a type. Okay, cool. So we'll talk about it again real quick. Causes include acute myocardial infarction. We talked about that. Congestive heart failure. Abnormal cardiac rhythms can cause us to go into cardiogenic shock. All right. We talked about the too fast and the too slows. Right. We get too slow. The heart isn't providing enough cardiac output, so our perfusion will fall. Too fast, and we don't get enough refill time, so then our cardiac output falls. All right, we can fall into that. There's several other, without going into a lesson on cardiology, which you guys don't necessarily need, right? There are several other rhythms that kind of fall into that kind of low perfusion, non-perfusion type rhythms. Therefore, this is where the ALS can definitely come in, because we can throw a monitor on somebody, find out what type of cardiac rhythm we've got that's causing us problems, and most of them we've got a drug for, or at least something we can do, right? Overdose, okay, on certain drugs again, can go back and cause some of the cardiac rhythm disturbances. They can cause problems with the heart's ability to function. They can they just kind of mess with all the different systems and can lead us into the fact where our heart is not beating and therefore our cardiovascular system is not working well, right? Our pump goes out. Questions on cardiogenic? Cool. All right, before we go into our body's response, we'll take a quick break, all right? Any questions on categories, types, anything like that, let me know, okay? Make sure you know the categories and the different types to be able to identify them, all right? Go take a break. It's 10:20. Come back at 10:28. 30 seconds. If there was a second hand, we would do that.
That's freaking disgusting. Are you serious?
He wants to taste the chemicals.
Oh my God.
Very small one, isn't it?
Yeah. Is it white now? I bet there's no brown yet at all.
Little tinge. Little tinge. Looks like,
Would you
looks
like
like
some
tea.
coffee for that cream?
Did you see how much she put in?
No, I didn't do it.
Like half a freaking container. I'm not exaggerating.
That's how I do it in the morning.
Wow.
I don't like coffee. This is the only thing that makes coffee
You
terrible.
don't like coffee?
I don't like coffee. It's awful.
Switch to something else then. You don't have to drink it.
There's tea with caffeine.
I mean, but I have to get it. I have to buy it in the morning. This is already here.
You're an interesting soul.
Sorry, hot chocolate though.
That was delicious.
No sugar?
I don't love the chocolate syrup in my coffee, so I like it to be like cocoa-y.
See? No judge.
Slight. Ever so slight.
You hear about the guy who recorded his colonoscopy and the doctors and the nurses were talking mad smack? And so he filed a lawsuit against them. And
How
what?
did he record it?
I don't know.
They said somehow his in his belongings bag, his iPhone got turned on or something like that.
Yeah.
So he's got
And he won like $500,000.
yeah.
Awesome.
I was kind of half asleep when it was on the news this morning, but it's like the one quote that they said was that the nurse was like, "Yeah, 5 minutes after I met you, I wanted to punch you in the face and man you up a little or something like that."
Because he was asking for more, and it's,
yeah, he was asking for something, and somehow his iPhone was on him.
yeah, and then
It
he had
was
like a rash on
in
his
his,
butt.
in like a belongings bag under the table. I don't know where it ended up being,
Man,
but
we
somehow
are
they have an
amazing.
audio recording of his entire procedure,
Crybabies.
and they were they were not saying some very nice
It was
things.
pretty funny. Like he had a rash on his butt, and the nurse and the nurse was like, "It's probably TV of the dick."
Yeah, there
Direct
was,
quote. Direct quote.
yeah.
Verbatim.
Whoops.
Oopsie.
Yeah, you know it happens every time.
It does. It honestly does.
That's why I did think it's happening can't talk. So it's,
They got it working for.
But I mean, why were they recording?
Whoopsie.
You know, so that the
And
cops,
the
cops don't
anesthesiologist
let
had to
them
cough
do
up
that.
like
The
28,000.
cops can't do that, use that
Just-
report
just
and
themselves?
do it.
Yeah.
They can do it,
But not
you know.
in an investigation, or just because of what they were
Just
saying?
because what they were saying.
You got that one local police
They were
officer.
charged with medical malpractice.
Homeless shelter,
Just based on what they were saying.
picking up homeless people. Which is
I have to watch that.
It wasn't even like really all that bad, honestly.
People are crybabies, anything to get a buck.
Otherwise, it's just too unknown.
Decided to retire from being homeless. You know that? I think it was the Vietnam vet that was, just chose to be homeless, but had the, you know, bank account. And there was a retirement day that's going to the bank account. He like went, he's like once a month and got his clean on, hotel sex, you know, it's like one day a month. Flutter can get a hotel room and a shower
So,
and
yeah, they.
take care of himself.
They do it well, because
Finally,
yesterday,
it's like, you know what, this is getting a little hard on me.
we got turned around to go for a flight.
Basically, I don't want to be homeless anymore. And went,
I think
said, I'm gonna buy a
I'm
house
call
and all this,
and
you
we're like,
know, 30
no,
years of
y'all
money,
can't have
saved
it,
up,
y'all have an ice sled.
had millions of dollars in
No,
the
we
bank.
have an ice
Now it's
sled.
like we're
We're
seeing
going
those
over.
whole
We're
fair
going.
Well, it's like,
So I was
you know,
like, why?
I'm not gonna buy a house, which like, maybe, well, I'm retired, homeless guy.
Yeah, say you need more than
Yes, this house is $4 million.
No, isn't it awesome? Yeah, it's kind of like,
That's pretty smart. I don't think that. Pretty smart.
Especially if you were already on.
Yeah.
I can't remember which team it was. There's a big league baseball player that's still living, he doesn't know that.
I was called up and said, look, we're gonna.
In the minors and everything, he talks about, he was those Walmart guys, because he talked about Walmart.
Buy. And then they called us as we were loading. And well, y'all want-
Drive his house, he's making $1 million.
For me and green cheese, I for that.
He says, how long will it change? I actually want to do it.
I saw you last,
Hey, you'll enjoy that until the first time you want to throw it. Your
Well,
voice,
it was cheese and sour cream.
not quite like a quarterback. I don't know what it is.
They're like.
You know what, I like the hot cream the best.
What is that?
It's a
Like when you're on the radio.
authentic Mexican sour cream that's really
Okay,
thick.
gotcha.
And I put little toes and different things in it.
Yeah.
You don't like it?
I mean, she takes it down, it's pretty down.
No, it's sour.
Well, and I didn't, like, I would like
Lazy
to
sour cream.
get a report of the trial, and I just go down and.
Well, it's very light and watery.
Reroute it,
But
Oh, yeah.
see
sour
if doing
cream,
anything,
and
and the truck can go get that other kid. And,
On that note,
as we were
I
getting
would
into the
be
thing,
perfectly happy if I went back to,
Shaw, we're talking about.
practice squad, make my league
I
minimum.
was like,
They're trying to take your.
And Michelle's like, no, they're just calling me. They want us to spend another, podcast there.
It's paid.
We were like, no,
He
why?
didn't have the facility to go there now.
Yeah.
Throat control.
Very good at communicating.
So, I was like,
Why are we shooting at You always want a gun has something in my general directions already. I thought that.
you smoked it first.
Huh?
Yeah.
No, wait.
No,
Negotiate,
it's
you
not
know?
opposite.
Well, I don't wanna get
I was
screwed
in
up
front
with this.
yesterday, I swear I was 20.
Whatever he
If
does.
you really love me, wouldn't worry about it.
But AC, it's like, the AC, I feel like I mean, if I said that, for a few minutes, we were.
I want to.
And then my, like, I pulled my phone up, my doctor.
That's what Taurus played there, but it's like, yeah.
She's like, no, no,
So I
no,
think it was her, that's Kelly Ryan.
all summer.
I wanna go to-
Oh,
get hurt, so.
When you get to destination, it's something how you come back.
I want to get a custom set.
Some guys.
Oh, that's, I hear about so a lot of problems in the
What's chaotic for one?
I don't know why really places to go. So we don't like college there.
Like, two
Is
crazy.
there something?
Oh, yeah.
Like,
Hey,
No, they were just doing all the things. Public exposure, drugs,
Because they should, think it should already been in shot, reality.
Well, like it shows that that's an state of
my two favorite. Like his first one.
All right, let's get back to it. All right, so we talked about the different types of shock, kind of how they occur, what causes them, that kind of thing. And we kind of, we talked about a little bit about some of the kind of treatments and what we want to kind of achieve, all right? So we've got the idea of what's going on. Now the kind of question is, how are we going to find shock? How do we see shock? What are we going to see? That kind of thing, all right? Most of our signs and symptoms, the stuff we're going to be able to see, assess for, evaluate, comes from what our body is trying to do itself to reverse the shock, or at least kind of try and compensate for it, all right? And that is what gives us our vital sign changes, our skin changes, the things we can assess for to say, yes, this person is in shock, put it together with the mechanism, and hopefully we can achieve and get to what type of shock they're in, and therefore we can proceed, all right? So, totally forgot that didn't work anymore. So the body attempts to compensate to return perfusion to normal, many signs and symptoms, all right? The sympathetic nervous system plays one of the most important roles in restoring our perfusion, okay? So we remember the sympathetic nervous system, yes? Okay, hopefully. All right, so basically what ends up happening is we get some form of insult or injury. We talked about the different causes, right? Our body starts to go into shock, meaning our blood pressure is falling, we're getting hypoperfused, all right, oxygen isn't getting where it needs to go, and so our body detects that, all right? Our baroreceptors detect the decrease in blood pressure, and they trigger corrective responses, all right? So we're now running, okay? So there are two pathways for our compensatory mechanisms to be stimulated and for them to come into play, all right? We've got direct sympathetic nervous system stimulation, all right, which is fast, immediate, that kind of thing. And then we've got hormone release, which takes a little bit longer to get in the game, but then sustains us for a longer period of time, okay? So the effects of sympathetic stimulation are immediate, okay? We get an increase in heart rate, right? So the first thing it's gonna do, all right, and is speed up the heart rate, okay? Remember, one of the things we wanna try and get to, right, is an increased amount of perfusion, which basically equates to we need our blood pressure to go up some, right? And we've got our cardiac output, which equals what?
Stroke volume times heart rate.
Heart rate times stroke volume. Okay? So in order to get our blood pressure to go up, we've got to increase our cardiac output. All right? One of the first and easiest things to do is just to jack the heart rate and make it run faster so it puts out more blood. All right? So that's one of the things we're going to see with our sympathetic nervous system. Okay? So the baroreceptors have seen the drop in blood pressure and perfusion. They've said, oh, that's not right. We need the fastest way. Nervous system kicks in. First thing it does, heart rate goes up, right? It's easy. Boom, heart goes faster, all right? The sympathetic nervous system is also going to increase, right, the force in ventricular contraction. Okay, so now it's running faster. Now it's pumping harder, so we're going to increase our stroke volume a little bit. So now we've got both sides up, hopefully. Now our cardiac output will go up as well, okay? In addition to that, we talked about the vasoconstriction properties, right, of epinephrine. Remember, epinephrine is basically a sympathetic mimicker, right? So we're going to get some vasoconstriction, all right? So the heart rate's up, the contractility is up, hopefully our cardiac output is up. So we've got more blood flowing. We're going to make the container smaller, all right? So now hopefully then we'll be able to restore our perfusion. Does that make sense? Okay. So we also get stimulation of the release of epinephrine and norepinephrine from the adrenal glands. Okay. So remember, we talked about the two different ways. We've got hormonal and we've got direct stimulation. Our direct stimulation runs all these things. It's quick, it's immediate, it's fast. Now we're starting to get into more of the hormonal side of things. All right. Which takes a little bit longer to get going, but the effects are much more sustained over a period of time. Okay. So epinephrine has alpha and beta effects that cause us to vasoconstrict, increase cardiac output, okay? Norepinephrine has alpha effects, right? It's purely alpha, and it constricts down those vessels and holds that tone for a longer period of time, all right? So now we've got increased heart rate. We've got all the things that we got out of the sympathetic system. We just have them now because of epi and norepi, and we're getting them for a sustained longer period of time. Make sense? All right. Remember, we've got so effects of alpha and beta stimulation. All right. So if we stimulate our alpha-1 receptors, all right, which come from our epinephrine and also our norepinephrine, right? We get alphas from both. All right. So constriction or contraction of the muscles controlling the iris. We also get contraction of vascular smooth muscle and vasoconstriction, and stimulation of our sweat glands, all right? So where are we going to see that in our patients? Well, if we get contraction of the muscles controlling the iris, that gives us dilated pupils, all right? I know it sounds a little bit opposite, but we get dilated pupils, all right? When we get contraction of the vascular smooth muscle causing vasoconstriction, okay? So if we vasoconstrict, right, especially in the little tiny vessels that are closest to our skin, what is that going to do to the blood that is in the periphery? Where's it going to move it? It's going to shunt it back, right? So now our skin is not going to have as much blood flow, so it's going to get cool, right? Because we don't have the heat from the blood flow. It's going to get pale, all right? And if you look at the next one down, we get the stimulation of sweat glands. We're going to see some localized sweating and some clammy skin. All right, so it's going to feel kind of moist, all right, and we call it clammy. It's kind of difficult to explain the term clammy, but it's a cool, moistness. Okay, I know everybody loves moist, right? What aversion to the word moist? Yeah. Okay, sorry. So we start to see it in our skin, right? And those are some of the earliest signs we see: the increase in the heart rate, the cool, clammy skin, that kind of thing. All right. On our beta side, all right, remember, beta 1, we have alpha 1, alpha 2, beta 1, beta 2, okay? The primary effects, 1 heart, 2 lungs. So if you're having trouble keeping those a little bit separated, that's a good way to remember, okay? So beta 1, it's going to increase our heart rate. It's going to increase the speed impulse through the conduction system, which means it's going to help our conduction system run at that faster heart rate. So we're going to see tachycardia, all right? So our heart rate's going to pick up. Increased force of contraction. Your patient may say they feel like they have a pounding heart, all right, because it's beating with a lot more force. On the beta 2 side, we're going to dilate the bronchial smooth muscle, which is going to decrease their resistance in airway, all right, and we could have some skeletal muscle contractility where we could start to see some tremors, all right. Going back to our bronchial smooth muscle dilation, all right. If we're going to start running our heart faster and stronger, what are we going to need more of to do that? Oxygen, right? Our myocardial oxygen demand is going to start to go up. So in response to kind of help that out, our beta side dilates our bronchial smooth muscle, makes it easier for us to breathe. So now we can start bringing in that increased level of oxygen, right? That the body's going to need to run the heart faster to keep everything pumping better. Does that make sense? All right. What do you think that's also going to do for our our respiratory rate? That increased myocardial demand is going to start to increase our respiratory rate as well. Okay. So there are other hormones that do things to decrease urinary output, increase blood glucose level, and cause further vasoconstriction, all right, as well as some increases in our cardiac output, all right. So the main players are epi and our norepi. We've got some other minor players that are going to decrease our urine output, all right. So we're going to start to kind of retain the things we need, all right. We're going to increase our blood glucose level, so we've got more available because as we're working harder, we're going to be burning glucose more. All right, and then we're going to cause further vasoconstriction, which is what we want because we want things to get kind of clamped down, shunt the blood, keep the more important things alive. Yes? All right. These are some other hormones that are released during shock. Okay, so we talked about epi and norepi, and then we've got the antidiuretic hormone or vasopressin, which is going to cause a decrease in urinary output and the vasoconstriction. Angiotensin 2 is a vasoconstrictor, helps speed up our heart rate. Aldosterone, sodium reabsorption in the kidney, which decreases urinary output. Glucagon is what gives us our increased blood glucose level. All right. So our epi and our norepi there at the top. Okay, those are our big major players. So if you look, all right, here's what it's causing on the effects of the body to try and fix. But then here's what we're going to see. All right, we already talked about tachycardia, pounding heart, pale, cool, clammy skin. We're also going to see an increase in our blood glucose level, dilated pupils. All right. So when we start to do our assessment, right, we think back to our primary assessment. We obviously check airway and breathing. All right. So our airway should most likely be fine unless there's some sort of injury to the airway is causing our shock, right? And then our breathing. What do you think we're going to see when we look at respiratory rate? It'll be up a little bit, right? Okay, good. And then when we get to circulation, here's where it's going to give us the biggest and first and earliest sign that our patient is in shock, right? When we go to check circulation. Because what things do we check when we're doing ABCs in circulation?
Skin color.
Skin color, temperature, condition, pulse, and cap refill maybe, right? Not as super reliable in adults, but if you've got everything else and a poor cap refill, well, then you've probably got an accurate cap refill. All right. What's that? Which IQ balls in the D or disability afterwards, yes. All right. But that pale, cool, clammy skin, that tachycardia, the first signs that we see of shock are right there for us in our ABCs. Okay. So when we look at somebody, we walk up and they've suffered some sort of traumatic injury, they don't look real good, and we get there, right? We do airway, breathing, the respiratory rate's a little bit up, we get to circulation, right? Their pulse is fast, it's weak at the radius, cool, clammy skin, right? Your shock bells should be going off, right? And your flag should be flying. Oh my gosh, this person's in shock. We got to figure out why so we can hopefully maybe restore it. Okay? So we've got several different stages in shock. All right? How long a patient stays in the stage is going to depend on severity of the injury. What stage you find them in, again, going to depend on severity of injury, your response time, et cetera, et cetera. All right? Some people stay in compensatory for a long period of time. Some people just hit all three of them real fast, depending on how severe their injury is. Okay? So your goal is to try and stop them where they're at. Okay? So if we're dealing with hemorrhagic shock, get there, plug the holes, get them supine, get them warm, get some oxygen on them, and get them to the hospital. Right? Stop them where they're at. All right? So the stages are compensated or compensatory, all right, decompensated, and irreversible, all right. So what are these going to look like vital sign-wise? Well, we're going to check, okay. So compensated shock. This is where the body is able to maintain a near normal, okay. So you may see just a little bit of a deviation to the low, right? So like where our normal, maybe we're going to see 120s, 130s. Now maybe we're going to see like 110s, 110 to 120, that kind of thing. Smidge low, but not like 80s, 90s, that kind of thing. All right. So a near normal blood pressure. All right, which is going to give us the perfusion we need for the vital organs. Okay. Blood is being shunted away from the non-vital areas, such as the skin and gastrointestinal tract. Okay. So shunting blood away from the GI tract is going to cause us to feel what? Nausea, right? So there's another sign or symptom we can look for if we've got a patient that can talk to us. All right. blood pressure may start to be becoming a little bit narrow. So as we see that near normal on the systolic or on the top, we're going to start to see maybe a climb in our diastolic as our body is starting to do what? Clamp down and constrict, right? So as we constrict, we make the container smaller, right? So therefore, the pressure in between beats is going to start to rise, all right? So we start to get maybe just a little bit of a narrowing, okay? These are going to be very subtle signs, all right? So when we look at your tachycardias, when we look at your heart rate, okay? So we're going to have our cool, clammy skin, right? It's going to be just mild, though. You're going to be like, yeah, that's all right. It's a little clammy, not too bad, right? Heart rate's going to be a little elevated, 110s, you know, maybe somewhere around in there, okay? We're going to have a little bit of an elevation in our respiratory rate, and then we're going to get to our blood pressure, right? And we're going to say, like 110, 112. We're looking at the person going, yeah, they should probably have a little bit higher than a 110 or a 112. So that's a little marginally low. Maybe our diastolic's up, okay? Everything's going to be real subtle, all right? But this is where it's probably the most important to try and catch somebody in shock and recognize it, start treating for it, and get somebody to the hospital so that they can stay in this compensated shock, because if we got to have somebody in shock, this is where we want them, because what are we still doing? We're still perfusing the stuff we can, right? Something's wrong, body's in crisis mode, but the things it's doing, right, are still maintaining and perfusing what we need to perfuse, okay? If we don't catch it in compensated phase, then we start to go into decompensated, okay? This is where the body has tried everything it can, all right? Its compensatory mechanisms are running full speed, but they're now not keeping up, all right? So we're going to start to see some decline in our vital signs, okay? The body can no longer maintain a blood pressure and perfusion of the vital organs, okay? We're starting to switch into anaerobic metabolism, okay? And our vital organs are not getting perfused, okay? So when we look at vital signs, we're going to see a pretty drastic, a decent uptick in our respiratory rate. Our heart rate's now going to be running like 120s, 130s, you know, those kind of things. We're starting to see some fast numbers, all right? And now our blood pressure is starting to fall, okay? So when we're talking about compensated shock, all of our vital signs are going to be normal or up, right? Blood pressure stays fairly normal, everything else is elevated, okay? When we get to decompensated, we've got elevation, right, in respirations, pulse, those type of things, but now we're starting to see our blood pressure come down, all right? Where do you think we're going to go when we get to irreversible shock?
Everything down.
Everything down, right? So if we don't catch them in decompensated shock, all right, we've got a couple more things for decompensated, all right? We're starting to get some microemboli, all right? They start to form in the capillary beds because we don't have the perfusion we start to get some pooling, so we're not moving things around. We start to get some microemboli. We get capillary permeability increasing, which means we're going to start to do what? Start to leak volume. Good. We've got decreased heart and brain perfusion, which is going to cause further failure of the compensatory mechanisms, resulting in a vicious cycle, right? So now we've gotten to the point, what ultimately is controlling our body's compensatory mechanisms? The brain, right? The sympathetic nervous system, okay? We stimulated that, and we got the initial compensatory mechanisms, and we got the hormone release that gave us our extended, all right? So if that's not working, we're still not perfusing. Now we're not perfusing the brain. Can the brain control the sympathetic nervous system to keep all those compensatory mechanisms on? No. So what's it going to start doing? Everything's going to start shutting down, okay? So we're going to start to get a vicious cycle on ourselves. You'll notice that there's a lot of these little vicious cycles within your body. They do really well at first, but when they get overwhelmed, and if we don't correct them over time, then they start to kind of double back on themselves and start to cause problems, all right? And shock is definitely one of them. So in irreversible shock, all right, damage is pervasive and severe, all right? Despite treatment, death becomes inevitable, all right? Irreversible, we call it that for a reason, all right? Because at this point, we're not going to get this person back, all right? Microemboli block capillaries, leading to multiple system organ failure, all right? So as those microemboli start to form, now they're blocking blood flow, and we're going to start to get organ failure. the body responds to the clots with what we call fibrinolysis, meaning it's going to start to release enzymes and hormones throughout the body that are going to prevent clotting, all right? Which, if we end up with our body telling us not to clot, all right? Let's say we're in shock because we were bleeding. Now what are we doing? We're doubling back on ourselves, right? Those vicious cycles, all right? So now we double back on ourselves and we start to get widespread uncontrolled bleeding throughout our body, all right? So, questions on compensated, decompensated, irreversible. Remember, compensated, everything up. Decompensated, everything up, blood pressure down. Irreversible, everything's down. So at this point in time, your patient's going to go from being extremely tachycardic, they're going to start being bradycardic, right? Their heart rate's going to start to slow. Their pressure's going to be in the toilet if you can actually find it. All right, everything's going to start falling, right? Whereas in compensated, everything's up, but it's just kind of marginally. Decompensated, we're going to jack the numbers through the roof, and the blood pressure is going to start to fall. All right? I would absolutely make compensated, decompensated, irreversible. Looking at vital signs, something that you study and can do, because there will be multiple questions that will give you a patient presentation with some vital signs and want you to know where they are in the shock process. All right? So, how do we assess somebody who is in shock? All right? The signs may initially be very subtle, or they can be pretty profound, all right? But rapid recognition is the key. So no matter what stage they're in, all right, we want to find it as fast as we can, recognize it, all right, provide our treatments that we can, all right, and get them to the hospital, all right? We're going to consider history findings, physical assessments, signs of perfusion disturbances, and vital signs. We're going to take our whole picture into account, all right? We talked about that earlier. How do we know which type of shock we're in? Well, we look at vital signs, we look at history, how they became injured, or medical history, right? Because these don't always have to be traumatic causes. They can be heart attacks, strokes, those kind of things, all right? Not necessarily strokes, sorry, back that up, check that. But they could be pulmonary embolisms, things like that, all right? So we don't always have traumatic causes, but we put together our history with our vital signs and our assessment findings, and we say, yes, this person is in shock, and we rapidly intervene and take them to the hospital. When we're looking at history, we're using our chief complaint. Don't forget sample, all right? And take into account, right, when we're talking about sample history, when we get to medications, all right, there are medications out there. They're very, very common, all right? And they're used to control heart rate and use that heart rate control to control blood pressure, okay? So ultimately, we go back to kind of our cardiac output here, right? Somebody has high blood pressure, they've got too much systolic blood pressure or diastolic, whichever one. One of the easy ways that they can bring the blood pressure down is by bringing cardiac output down. You give them a beta blocker, which is what the medicines are called. It keeps the heart rate slow, okay? So beta blocker patients sit like some of them sit like upper 50s, some of them sit in the 60s. And because of that blockade that the medication provides, they can't increase their heart rate in response to shock, because we've artificially blockaded their ability to increase their heart rate, all right? So if you've got everything else pointing to shock, right, and you're like, oh, what, their blood pressure is like only like 60 or 70, all right, but their blood pressure, their pressure's in the crapper, and they've got this big traumatic blood loss and all that kind of stuff, right? You get the sample history, and you're like, oh, what past medical problems do you have? Oh, I've got hypertension. Cool. What do you take for it? Oh, what do you know? Beta blocker. Crap. Right? Now we know that they're going to run those phases a whole lot faster, because that primary mechanism of speeding up the heart rate is out of play now. So they're going to hit decompensated irreversible in a lot faster succession than somebody who has the ability to get their heart rate up. Okay? Beta blockers are very easily recognized, right? Calcium channel blockers are out there as well. Beta blockers, they all end in OL, OL, or ILOL, right? So metoprolol, carvedilol, I can never remember medication names. I don't ever pronounce them anywhere near where they're supposed to be, right? But if you're looking at the patient's medications and it ends in OL, OL, or ILOL, doesn't matter what the first section is, that's a beta blocker.
But they've all got different names, like carvedilol is also chlorate.
Yes.
So that'll throw you through a loop.
Yes. Well, we'll talk about pharmacology when we get into the medical chapter. There's trade names, there's generic names, right? So if you're on a trade name medication, you're not gonna be able to pick it out quite as well, right? But with changes to Medicare, hey, so many people are on generics nowadays, so it's pretty easy because insurance companies don't want to cover the brand names. So, but yes, you are correct. There are some out there that'll fool you. Okay. But if somebody says they've got high blood pressure and you're noticing shock signs except for a heart rate, okay, put it in the back of your head. Maybe they're on something that keeps their heart rate down, and and go with it from there. Physical exams, okay. Remember, vital signs can initially appear normal in compensatory shock. So we're going to look for signs of poor perfusion, including, what do you think some of these are going to be? Pale, cool, clammy skin, right? We're going to look for a narrowing of our pulse pressure, right? So even though our systolic pressure may look normal, we start to see that diastolic creeping towards it. Could be a sign as well, all right? Increase in respiratory rate, all right? We can also get a delay in capillary refill, poor SpO2 readings, those kind of things, okay? It goes through by the different types of shock. You can definitely check those out in your book, right? It's going to be different things based off of the different types, all right? But basically, your compensatory mechanisms are going to look mostly the same, all right? So age may influence the development, presentation, management, and recovery from shock, okay? So remember, we talked about the really young and the really old and how they compensate, right? Really young, stay up, and they compensate, and they compensate, and they compensate, and then they basically skip decompensated and go straight to reversible, right? Old people, they just fall off, right? Because they don't have the ability to compensate. So remember that that they can present very differently, all right? So our general goals of shock management, okay? Patent airway, establish and maintain adequate ventilation. So we do our ABCs, right? We want to make sure our airway is clear. We want to make sure that they're ventilating appropriately, okay? If they're not doing it on their own, then we need to do it for them with the bag valve mask, okay? And then establish and maintain adequate oxygenation, okay? Remember, ventilation and oxygenation, two different things, all right? We want to make sure that not only are we moving the air in and out, but we want that air to contain as much oxygen as possible so that we have the best chance of getting the most oxygen into the system to help try and restore the perfusion, all right? We do not want to hyperventilate the patient, okay? When we're talking about back valve mask respirations, right, the old some is good, more is better is not so much the case, okay? When we hyperventilate a patient, we don't allow them to fully exhale, all right? That extra air stays in the lungs, okay? And creates more dead space that we have to overcome with the next ventilation in order to get oxygen, actual air with oxygen to the alveoli. And two, it starts to increase the intrathoracic pressure, okay? The bigger the lungs are, the more the pressure is inside the thoracic cavity. What that'll start to do then is start to interfere with the body's ability to return blood to the heart, okay? Remember, the venous side of the system is low pressure, all right? It doesn't have that contractile force behind it that the arterial side does. So if we've got an increased pressure in our thoracic cavity, that venous side can't push against that pressure nearly as well, and so we start to get a decrease in venous return to the heart. A decrease in preload equals a decrease in what? Cardiac output, which equals a decrease in blood pressure. Is that what we're looking for right now? No, we're kind of fighting against ourselves. We're creating a hypoperfused state in a way if we're hyperventilating and increasing that intrathoracic pressure. Does that make sense? So we keep a normal, non-hyperventilating rate, okay? That 10 to 12 a minute that you're looking for, right? 1 every 5 to 6 seconds. That's where we want to stay. You can almost even take it down a little bit, right? We ventilate our cardiac arrest patients at 10 for that exact reason, is we don't want to increase the intrathoracic pressure. We keep it even a little bit lower, okay? So ventilation is good, overventilation is not, okay? So the old some is good, more is better is definitely not an okay theory when we're talking about artificial ventilation. Make sense?
I wrote it a little bit. Doesn't that actually change with like certain head injuries though?
A little bit. We'll talk about it when we get to head injury. It's a very slippery slope, but yes.
So I confused the hell out of things.
Yes. Basic nuts and bolts, right? Carbon dioxide is a vasoconstrictor, right? So if we, or no, vasodilator, because we're trying to get rid of it when we hyperventilate. So it's a,
That's how high it is, I guess.
yeah. So it can be a vasodilator. So what we do, what you're talking about in the head injury, there's some theories out there, and like I said, it's a real slippery slope, and you got to be very careful playing with the numbers. They'll hyperventilate ever so slightly a head injured patient to blow off that CO2 so that it's not dilating the vessels in the brain, and so that it's kind of bringing them down to relieve pressure. Problem is if you blow off too much, you get constriction, and then you cut off blood flow. Right, so now you've got to play. It's a real slippery slope, and the book talks about it a little bit, but we'll cover more in the injury. So,
There are some quiz questions that come at it.
yeah, it is a best general practice not to hyperventilate your patient. If your protocol allows for it in head injury specific patients, then there is. But your best general practice is don't hyperventilate people.
Let the hospital take care.
Yeah, and like I said, unless you've got some way to monitor your CO2, like it's a real slippery slope. Like little bit too much starts to make a negative difference. So we want to stop bleeding as quickly as possible. Okay, remember at the basic level, we don't have a whole lot of ways to put things back, right? So we got to plug the holes as fast as we can. It's a principle on the ALS level as well, because I can put as much fluid as I want into somebody. If it's still running out the hole in their chest, well, it really doesn't do any of us much good. All right. So plug holes, get the bleeding stopped as quickly as possible, okay? We're gonna splint fractures if we have our time, or we can do so en route, all right? We don't wanna delay transport for these, okay? The reason we're gonna splint fractures is because we can actually prevent some blood loss from a fractured bone if we can splint it appropriately. But typically with most of our breaks, okay, if we're not talking about like a pelvis or a femur or something along those lines, the blood loss is gonna be fairly nominal. So we're going to go ahead and, forego that in favor of getting somebody to the hospital. Do not remove any impaled objects as they can cause further bleeding. All right. Maintain the body temperature. Keep them warm. All right. I'll get to you in just a second. Part of the reason we want to maintain the body temperature is below 95 degrees on the core body temperature, your body starts to lose the ability to clot. All right. So if you've got some sort of internal damage and you're losing blood internally and you don't keep them warm, you're giving them an opportunity to not clot. All right. Because cold patients don't clot. So therefore, you're going to kind of cause a problem. All right. So that's why the part of the keep them warm comes into play. All right. Trauma surgeons get very angry with you if you deliver cold patients to them, because then they take them to the OR and they're trying to stop bleeding and plug holes and everything like that. And they've got a patient that won't clot. That's why if you ever go into any of the good trauma facilities, right, if they're spun up appropriately for a good trauma patient, the doors will be closed to the room when you get there, and they'll pop them open. You'll walk in and it'll feel like a sauna in there, because they'll have at BRAC, there's actually like 3 buttons on the wall. One says cold, one says normal, one says hot. And then somebody reaches out and punches the hot button. Within about 30 seconds, the temperature in that room gets to almost an uncomfortable level, because that's how warm they want to keep their patients and how important it is to them. All right, so keep your patients warm. Keep the patient supine, all right, going to give you the best chance to keep their blood pressure up at a level where hopefully it'll perfuse what it needs to perfuse. You, sir, had a question?
On my homework last night, I was doing for this chapter, there was a question about someone that got impaled by a tree branch, but the answer was remove the object.
So
That's going to come up in any advanced reading.
Yeah.
So there's certain things that are going to come up in terms of scenarios, right? General rule is going to be not to impale. The rule basically stays don't remove an impaled object unless it prevents you from being able to transport the patient, right? Obviously, we can't take the large tree branch in the back of the in the back of the ambulance, all right? Where they might have been going, because now you bring the neck into it, if it involves airway, then we absolutely have to take it out, because we have to get that patient get an open airway of some sort, right? So that probably was going to be their caveat, was that they put it in the neck. It's an airway compromised issue. We're going to take it out, right? So if it's too big to transport or causes an airway issue, we're going to take it out. Otherwise, leave everything else in. Yes, sir.
If you remove it from the neck, it wouldn't cause like too much bleeding through the airway.
It's a 6-to-1, right? We got to take risk reward. If we leave it in and we can't oxygenate or ventilate somebody, it really doesn't matter if they bleed out, because they've got no oxygen to circulate anyways, right? So we'll take the opportunity to possibly stop the bleeding and be able to oxygenate them and move air over if we leave it in and we can't oxygenate and move air, they're dead anyways. So risk reward scenario there, my friend. Not an enviable position, but one you may have to make. All right. All right, we're gonna apply our anti-shock garments. Okay. What the PASG is, PASG stands for Pneumatic Anti-Shock Garment. Anybody who's familiar with fighter pilots, right? They wear the G suit on their lower extremities. It inflates in high G situations, shunts blood up to the core. All right. Basically, that's what it is. It's a pair of pants that wrap around their legs and their abdomen. You pump it up really far, and it starts to shunt blood artificially. Okay. It is old. It is antiquated. There are very few systems that still use them. So that's why it says according to protocol, because you got to find a system that actually still uses them in order to use them. There's still a national registry skill. We'll cover them a little bit later on in our skills. Why they're still in there, I don't know. I don't foresee them lasting too many more years on that one, unless it's one of the things that, you know, everything in medicine comes in, goes out, and then comes back in again. I don't foresee the shock garments coming back in again, but you never know. All right, so if you can find them, great, use them. If not, don't worry about it. All right, rapid transport is number one critical, right? We call it the platinum 10 minutes, and it refers to
the maximum time you spend on the scene of the trauma patient.
right, our scene time goal with a trauma patient, 10 minutes. Okay, critical trauma patient. Don't just think every trauma patient, because you'll get that quiz question wrong.
That means only say.
Critical trauma patients. All right, and then we're going to consider our ALS intercept with our standard ALS rule, right? If we can get them to the hospital faster, don't worry about ALS. If we can get them to ALS faster than the hospital, then we'll get ALS. Sound good? Yes, sir. Indeed. All right. Any questions on shock before we move on to the ultimate shock, which is cardiac arrest?
Not
Yes,
a
ma'am.
shock question, but like, so when you intercept with ALS, how quick can you guys hand off? Because that's another.
It really depends on how the system works. In a lot of cases, what it'll be is some cases that ALS truck is like a two-person truck, and what it'll be is literally you pull up on the side of the road with the ALS group, and the BLS guys stay in the truck. The ALS guy just grabs his gear out of his truck, jumps in the back, and they hit the round running, and they do the, he's like, okay, what do you got, right? And they work through it on the way. Some systems that most of them are kind of built that way. Even if the ALS provider is running like a single person kind of thing, what will happen is he'll grab his gear, jump in the back, grab a quick report. One of the EMTs will drive his car, the other one will drive the ambulance. It really just depends on system setup. Sometimes they'll just leave it wherever they can, and the ambulance will bring the ALS provider back to it. If they do have to actually make a swap, meaning they move it from the BLS ambulance over to the ALS ambulance, it's usually a fairly quick down and dirty handoff report, and especially if you've got a conscious patient that ALS provider can talk to, he's going to get the real quick nuts and bolts, and then he can ask questions on the way if he needs to. Like I said, it really depends, but usually it's not too long or involved of a process. I mean, we can usually make a transfer to a flight program within a few minutes. They really don't want to stay on scene very long because, one, it's a safety issue anytime the helicopter's on the ground running. But yeah, I mean, I can pass the patient to star flight by the time we get them loaded onto their gurney and out the door. Because what will usually happen is one of the crew members will come up, we'll go straight to the patient and start working on packaging. The other one will come up and get a report from the lead provider, and then everybody just kind of close out the door.
Do you do one of the write down report things?
If I have the time to, I'll write down a few things. If not, typically what they'll do is come in with either like a blank sheet of paper or just start taking some quick notes on their glove and get out the door, and then do everything else later. And then I can send them a copy of my report later, or they can pick it up from the hospital or one of those two. So usually it's a pretty quick ordeal.
It just sucks when you walk and the whole trauma team's there waiting for you and you don't know half the shit and they're asking you questions like, oh no, it's like
Yeah. Yeah, well, sucks to be the trauma team at that point, huh?
Yeah, they make you feel like
They do. It's a crappy feeling, but bottom line is we got the patient here in a hurry, right? So, cool. Any other questions? All right, awesome. So we're gonna move on to resuscitation and cardiac arrest, okay? Kind of the ultimate shock, if you will, right? Everything is shutting down. We're done. We're gone. Now it's time to make the undead dead. All right, or excuse me, the dead undead. Typically, what we try and do is make the dead undead. Usually, kind of counterproductive to try to make the undead dead. But so resuscitation means bringing a patient back from potential or apparent death. All right. Resuscitation focuses on management of airway ventilation, oxygenation, and restoring adequate circulation. If we're having to do cardiac arrest resuscitation, our main goals stick primarily to ABCs, right? That's our big thing. Fix ABCs, restore ABCs. Eventually, we'll maybe get to a few of the questions when you get ALS providers on scene. We start to look for correctable causes because we have ways to do it. At the VLS level, push hard, push fast, squeeze the bag. That's cardiac arrest management. Use your AED. So cardiac arrest occurs when the ventricles of the heart are not contracting or cardiac output is ineffective and no pulses can be felt. All right. So it's entirely possible that in some of these cardiac arrest cases, there could still be some contractility of the heart taking place. All right. In that case, what we probably call it, we'll talk about it in a little bit, called pulseless electrical activity. Meaning we can see the electrical activity. If there is a little bit of contraction, then it's there, but we can't feel any pulses, so we treat it as cardiac arrest, and we go from there. All right. So brain cells begin to die within about the first 4 to 6 minutes following cardiac arrest. All right. So at 4 to 6 minutes from cardiac arrest, brain cells begin to die. As we start to lose brain cells, we start to lose chances of survival and discharge from the hospital with a neurologic outcome. All right. So if you think about it, all right, did I tell you? I told you we've got the #2 cardiac arrest survival, right? And then Seattle area, Portland, those guys, they have up in the Pacific Northwest have the #1. And part of the reason why is because of layperson CPR, correct? All right. So if we think about it, if somebody goes into cardiac arrest and nobody does CPR, all right, it takes a minute or so for somebody to recognize it. You call 911, they dispatch us probably another 30 to 60 seconds later. We've got about 60 seconds to 2 minutes, depending on the department, to get to the truck and get on our way. And then we've maybe got about 4 to 5 minutes to drive to the call. Where are we at if nobody's doing CPR? That was probably easily about 6 minutes worth of stuff in best case scenario land, right? So if we're losing brain cells at six minutes and we're not even getting there, all right, you've had possibly as much as 2 minutes of brain cell loss before somebody even gets there to do CPR, all right? So that's why bystander CPR, education, all that kind of stuff becomes very critical, all right? A common cause of cardiac arrest is ventricular fibrillation. Okay, ventricular fibrillation can be treated with defibrillation. Okay, so if we're fibrillating, we want to defibrillate you, right? Using means we take electricity and we take you out of fibrillation. All right, we'll talk more about electricity here in just a little bit. So during cardiac arrest, our patient goes through 3 different phases, okay, that then ultimately lead to their biological death. Okay. And these phases are fairly important because what phase we find the patient in kind of directs our priorities on our cardiac arrest care, all right? In terms of what do we do first? Do we start CPR? Do we go right to the AED? Those type of things, okay? So the electrical phase, all right, is the first one. It lasts for the first 4 minutes after cardiac arrest, all right? The heart still has enough oxygen and glucose, all right? And therefore, conditions are favorable for resuscitation, meaning the heart is ready to respond to defibrillation, okay? Something's going wrong with the electrical activity. We just got to give it a quick little shot and hope it resets. And we've got oxygen and glucose already present, all right? So we're still early on. There's still oxygen reserves. There's still glucose reserves sitting in the heart. The heart is ready to go. We just got to hit the reset button, all right? That is the electrical phase. The circulatory phase then runs from minute 4 through minute 10, okay? And this is where now we've used up our oxygen and our glucose stores, all right? And our myocardial cells in our heart are now switching to anaerobic metabolism. Uh-oh, right? That's never good for anybody, all right? At this point in time, we need to do some CPR for them to restore the supply of blood and glucose to enhance the possibility of successful defibrillation, okay? So in that first phase, everything's ready for defibrillation. We can go ahead and do it. It'll respond great. Once we cross into this circulatory phase at the 4-minute mark, all right, now we've got to do some CPR because we've got to get blood back to the heart. We've got to get oxygen and glucose so it'll start again, okay? Who mows their lawn, right? Where are my lawn guys at, right? So you don't mow it, so don't use the lawnmower a whole lot in the wintertime, right? First time you pull it out at the end of winter or the beginning of spring, how many times you got to pull that rope to get it going? A lot, right? Okay? That's your heart in the circulatory phase. All the fuel, all the oil, all the everything is settled. It's not where it's supposed to go. And you've got to basically prime up that engine, right? You push the little bulb a few times, you pull the thing, and eventually it'll get started. Okay? The priming and the pulling of the chain is us doing CPR. Puts everything back where it's supposed to be, makes conditions favorable for it to start. Right? Once you do that, then, right, you mow, you stop, you empty the bag, you go to pull the chain. When does it start? Starts on the first pull, right? Because everything's still there. That's us in the electrical phase. Okay? Everything's where it's supposed to be. Okay? Everything's primed, we defib it, it starts. Okay? Make sense? Kind of follow the logic there a little bit for those lawn care individuals. Okay? Everybody else, no CPR, CPR. If we don't catch it in the circulatory phase, then our last one is at the metabolic phase, and this is from 10 minutes on. Okay? The heart muscle is very acidic from being in its anaerobic metabolism. It's ischemic because we haven't had oxygen to it in a really long time, and it begins to die. And obviously, when we have dead cardiac muscle, our chances of resuscitation become very, very, very slim. Okay? So, the 3 phases. So, remember those 3 phases? We're going to talk about a couple other terms, and then we're going to kind of revisit the thought process behind some of those phases. All right? So, downtime, okay? Downtime refers to the time from the patient's going into cardiac arrest to somebody doing CPR. Okay? That is the downtime. So, downtime, arrest to CPR. The total downtime is from arrest to ED, or the amount of time, or when a paramedic says, nope, we're done, and gets the time of death. All right? So total downtime, arrest to ED, downtime. So when I walk onto the scene, I want to know the patient's downtime. That was how long did they arrest before somebody did CPR. Okay? If nobody's doing CPR, well, then the downtime is from the arrest to whenever one of us starts. Okay? Return of spontaneous circulation, or ROSC, okay, means their heart wasn't beating, we worked them, now it's beating on their own. Okay, so we got them back. This is where we get a return of a pulse. All right? Survival then refers to, for you to have cardiac arrest, survival, meaning you survive long enough to go through the rehab process and get discharged from the hospital. Okay? And typically when we look at survival numbers, we add a little extra onto that, and it's called neurologically intact, meaning you can function in daily life when you discharge from the hospital. Okay? When we discharge somebody from the hospital and they're in a comatose, vegetative state, that kind of thing, most of the time those people don't count towards survival numbers. All right? But your book defines survival as surviving the cardiac arrest and being discharged from the hospital. Okay? If we get spontaneous circulation on you and we take you to the hospital and you still got a heartbeat and 2 days later you die, you don't count in the survival numbers. All right, you got to get discharged from the hospital to be a survivor. So, we have 2 different types of cardiac arrest. Okay, we have a witnessed cardiac arrest and an unwitnessed cardiac arrest. Okay, so witnessed is just that. Somebody saw the arrest happen, and we know the downtime. What was the downtime again?
Time from cardiac arrest until effective CPR is being performed.
Cardiac arrest to CPR. Good. All right. So we know how long the downtime is. Okay. So if we get on scene and we say, hey, this guy's in cardiac arrest, did anybody see him go into cardiac arrest? Yes, I saw him. About 30 seconds later, I started CPR. So our downtime then is 30 seconds. Okay.
The book says that just a lay person doesn't count that.
I have a problem with that, because if the layperson is doing effective CPR, then, right? If they're doing something that doesn't look like CPR, we won't count it, right? But we'll go Because we all know that if you haven't been trained or you haven't done it a few times, you're probably not going to be very good at it, right? So if the book doesn't count layperson, then if there's a question that asks, don't count layperson, right? What's most likely going to ask, right? And here's the biggest thing, is we want to take this downtime and we want to evaluate what it is, all right? So your test question is going to give you a downtime, all right? They're going to say, you arrived on scene of a cardiac arrest and nobody was providing CPR for the last 5 minutes, all right? Now you know what your downtime is, okay? If their downtime is known, okay, if it is less than the 4 to 5 minute mark, we're going to immediately start our AED and its process right there, okay? Because what phase are we still in? Electrical, right? And in electrical phase, we've got everything we need. We just got to defib it, right? It's primed, it's ready to go. It's going to respond well to defib. If that downtime is greater than the 4 to 5 minutes, okay, what phase are we now in? Circulatory. And what do we need to do to restore the blood and the glucose? Got to get some CPR. We got to prime the pump, right? So we're going to prime the pump with 2 minutes of CPR. Then we're going to throw the AED on and run it because our success rate is going to be much higher that way. Does that make sense? See where downtime comes into play, right? So real world field application, okay? If I walk on scene and somebody is doing some awesome layperson CPR, okay, I'm going to count that as a downtime and I'm going to do what I need to do, okay? Book doesn't like lay people, fine, whatever. Okay, don't like lay people if you're answering a question about downtime. Okay, but the big thing is we want to know what that time was. Okay, less than 4 or 5 minutes, go to the AED. Take advantage of the fact that you've got favorable conditions. Greater than, make yourself some favorable conditions by doing CPR. Fair enough? All right. If we have an unwitnessed cardiac arrest where no one saw it happen or nobody can give us an accurate downtime, right, then we're just going to assume it's been too long and we're going to hit 2 minutes of CPR before we do the AED. Okay? Sound good? Aha, the chain of survival. Okay? So, successful resuscitation depends on a sequence of events. The chain of survival is slightly different for pediatric patients. The one you see here is for adult patients, okay? The emphasis is on high quality chest compressions and early defibrillation, all right? In your book, it gives each one of these chains, right? It gives it in order, and it gives it a specific name. They may not make 100% sense as to where they fall as to how they are named, okay? Go in your book, know which one, what each one of these is called, and the order. Because there's a question on the test, right, that asks you about one of the steps in the chain, and the way the book names it doesn't make a whole heck of a lot of sense for what it actually means. All right? So if you want to get that question right, inevitably somebody's not going to look at the book and you're going to argue the question with me because you're going to be like, I thought the answer was C because it made sense, and this one, it just doesn't make sense. I'm telling you now, okay, the names of the chain links don't necessarily make 100% sense for what they actually are. So go in, look at them, memorize them, know them. Yes? Okay. If you forget, right, you will either A, remember it as soon as you get to the quiz, or B, and when you get to exam time, it'll be on the review. All right? So our rationale for early defibrillation. Why are we wanting to defibrillate as fast as we can if we have favorable conditions? Okay. Well, the most frequent initial rhythm in sudden cardiac arrest, okay, is ventricular fibrillation. That little bullet point there will be a quiz question. Make sure you remember it. It is uber important. Okay. It's important here. It's important in EMT. It's important in paramedic. If you're going all the way, you might as well stop and memorize it now. Okay. So the most frequent initial rhythm in sudden cardiac arrest is ventricular fibrillation, all right? The most effective treatment for ventricular fibrillation is defibrillation, okay? Electrical therapy, all right? The probability of successful defibrillation decreases pretty severely over time, all right? So successful defibrillation depends on effective CPR. Interruptions and chest compressions for defibrillation must be minimized, okay? When they go back and they look at our CPR data, because our cardiac monitors nowadays are smart enough and the technology in them is good enough that we can go back and look at literally the graphic representation of every single chest compression we did. We can work cardiac arrest for an hour, and they can send us a printout and show us literally every single time we push the chest and how effective it was. All right? So what we do then is in our protocol, our interruptions, 10 seconds. If we get interruptions greater than 10 seconds, we're going to hear about it from our QA/QI folks. All right? Meaning even when we stop trying to interpret a rhythm, we got 10 seconds. From the time that guy comes off the chest to look at it, decide if we're going to defib it if we're going to, and get back on the chest, 10 seconds. All right? So interruptions in CPR to a minimum. All right? If you got to move a patient, it needs to be well coordinated, well timed, small movements, less than 10 second interruptions. Okay? You want to make sure you're keeping your interruptions in CPR at an absolute minimum. All right? Because what happens then is every time you start CPR, we talked about it a little bit in chapter 1, right? We build up that pressure, and every time we stop, what happens? It goes right back down, and we basically start our initial phase of our cardiac arrest again, right? And if we don't restart it and get us back to favorable conditions, then our defib is not going to work well. Yes, the AEDs run a little slow, so don't panic. If you're following the AED and it says stop compressions, don't touch, reanalyze it, and you're like, oh crap, it's greater than 10 seconds, let the AED work, right? That's built in. You can't do anything about it. That's how it works, all right? But you shouldn't be interrupting it for anything else. It says don't touch, I'm analyzing, you're off. It says no shock, you're right back on, okay? Or it shocks, hit the button, right back on, okay? Minimize your interruptions, okay? Without intervention, ventricular fibrillation degenerates into asystole, which is the ultimate bradycardia. It's flatline. It's what the movies like to show you, and you're dead. Yes, sir?
I was just going to say, if you shock and then they go.
Even if they go back into a perfusing rhythm, 2 minutes of CPR is not going to hurt them. It's only going to help a weak heart.
Okay.
You can't do anything to it. You're not going to do anything worse than what they already were. Yeah, we used to play around with, we shocked them, then we checked and we waited, right? And we're like, oh, maybe we feel. Man, those initial rhythms coming out of ventricular fibrillation or anything like that on a defib, even coming out of asystole, those first reperfusing rhythms are not very good. They're not very organized. They're usually real slow. They come out of the ventricles and they're not real strong. So helping them out by pumping for them for 2 more minutes is only going to help increase the oxygen flow and get that reperfusing rhythm back to something that's even better. So, common question, great question. There's your answer. Sound good? All right, push hard and push fast, all right? To perform effective CPR compressions need to be at a rate of at least 100 a minute, all right? Our compression to ventilation ratio is 30:2. Once you get ALS involved and they get an advanced airway place, those kind of things, we stop counting, we just keep pushing, and we do what we call asynchronous compressions and ventilations, where the guy who's ventilating squeezes his bag at whatever his rate is, the guy that's doing compressions does compressions, and we don't worry about the interaction between the two, all right? So we minimize interruptions for defibrillation, we talked about that, and we avoid excess ventilation. We talked about why it's not good to hyperventilate somebody in shock. It's especially not good to hyperventilate somebody in cardiac arrest. We increase that intrathoracic pressure. We interfere with return to the heart. Preload drops. Therefore, our cardiac output drops, and it's kind of not what we're going for when we're trying to resuscitate somebody. All right. We talked about some of the compression-only CPR and how we got there, right? There's oxygen reserves for a decent amount of time, right, in cardiac arrest without even providing any supplemental oxygen. So that's why our respirations in adults have kind of taken a back seat to CPR, right? We've slowed ours all the way down to 10 a minute. There's some programs that show up on scene and they put an auto breather on the guy and they do 200 compressions before they ever give him an artificial ventilation because there's more than enough oxygen left. That's how important the emphasis they put on CPR. All right, so it's kind of hard to not get excited when you're working a cardiac arrest and just start squeezing the bag, but keep it nice and slow. Okay, we use what's called an impedance threshold device. I believe it talks about it here later in the chapter. It's got a little blinky light on it, right? We've gone to a lot of visual aids to keep people's respirations slow. You only squeeze the bag when you see the light. All right. So we talked about doing resuscitation. We need to make sure we know when also to withhold resuscitation. Covered this a little bit when we talked about medical, legal, those kind of things. All right. Remember, if we have a do not resuscitate order, it must be complete. It must be fully filled out. All right. Physician's orders for life-sustaining treatments, those apply mostly to the emergency department. that's one where you're going to have to get on the phone with the medical direction and see exactly what they want to do. At that point in time, you don't necessarily have the ability to follow those and withhold treatment. All right, we take the out-of-hospital DNR and that's it. Okay, everything else is phone a friend, run it through somebody that makes decisions at a higher level than you do. All right, even as a paramedic, I'm not making a call off of a physician order for life-sustaining treatment. I'm calling the doc at the hospital or my medical director to see what he wants me to do. All right, same thing with medical orders for life-sustaining treatment. Injuries incompatible with life. Okay, if you're missing your head, you're obviously not going to live. We can pump chest all day long. If the head's not attached anymore, it's not going to be successful. All right, so you look at injuries and you think to yourself, right? So like decapitation, incineration, exposed brain matter, all those kind of things, count as injuries that just are not compatible with life. All right. So some of our tools of resuscitation, we've got AEDs. All right. For the AEDs, we've got a couple of different types. All right. We have manual defibrillators, which require extensive training and use. That's what we use as paramedics. Okay. There are multiple different brands out there. Or we have automated defibrillators, which are actually our AEDs. And those are a lot simpler to use. We train the lay public to use them. They're a BLS skill. They're in the back of a lot of cop cars, all those type of things. Okay. One of the first cardiac arrest saves I had here in the state of Texas after I came here was thanks to the Bee Caves Police Department. They shocked some dude over at the Galleria Mall, and he had a perfusing rhythm by the time we got there. So advantages of AED, speed of operation. I kind of question this one a little bit. A fairly highly trained paramedic can take a look at a rhythm and do it, in my opinion, a little bit faster. But your book says speed of operation, so if you're answering questions, the AED does it faster than your paramedic with your manual defibrillator. Okay, they have safer, more effective shock delivery. All right, and more efficient monitoring. Okay, the algorithms and the brains of an AED, all right, are very highly sophisticated. Their algorithms are really good. And they are actually really accurate at determining the types of rhythms and deciding whether to shock or not shock, right? So when we put them in the hands of somebody who has zero training medically whatsoever, other than how to use the machine, right? We want to make sure that that's the case, and they actually do perform pretty well, okay? There are two types of AEDs, fully automated and semi-automated. I would absolutely know the difference, okay? Fully automated means as soon as you turn it on, you're at its disposal. It's just going to run every sequence it has without any input from you. Meaning when it gets to the point where it's ready to shock, it's going to charge its battery. It's going to say, stand clear, shocking. And if you don't stand clear, it's going to shock without any input from anybody else. Okay, so you got to make sure you listen to it. When we first started, fully automated was kind of the way AEDs went when they first came out, right? You can notice some obvious safety concerns with a fully automated AED, right? The only way to stop it from shocking is to turn it back off, all right? So if you don't have a good scenario where everybody's not clear, that kind of thing, you can see where some safety concerns would happen there. So we've gone to mostly what we now have is the semi-automated defibrillators, meaning you turn it on, it runs its sequence. When it comes time to shock, somebody's actually got to reach down and push the button and deliver the shock, all right? So AEDs have gotten kind of, they're pretty mainstream now. Everybody's pretty familiar with them, so the hesitation to push the shock button is far less than it was when they very first came out, which was kind of an advantage then of the fully automated, is you didn't have somebody going, I don't know, right? The machine just went, done, did it, okay? Now we've got them a little bit more mainstream. Most people are pretty okay with pushing the button, all right? Depending on their age, AEDs may use what we call a monophasic or a biphasic waveform, all right? Monophasic is starting to become pretty old technology. Just about everything made nowadays is using biphasic waveform. Monophasic and biphasic basically just means the electricity travels from one end to the other, right? So a monophasic, it travels one direction. Biphasic, it travels both directions. We get a lot more, we can use a lot less energy and get a lot more effective defibrillation out of a biphasic than a monophasic. So just about everything made nowadays comes biphasic. Some pictures of some different brands, okay? You'll notice there are various different brands. They all pretty much look about the same, right? They've got an on-off button, they've got a shock button, and a place to plug pads in. It's really simple, all right? It's kind of hard to screw up. When we talk about pediatric patients, okay, just about every AED should have some form of pediatric pads to them, or some form of what we call a dose attenuating device, all right? Here it's in line with the pediatric pads. You see the big Cardiac Sciences blue box there. Basically what that is the AED is going to deliver a shock at the same joule level, right? It sets kind of one level for adults, right? It's set for adults. And what that happens is when we plug this pad in, that then restricts down the electricity level to a more appropriate level for a pediatric patient, so we're not sending the patient with as much electricity. All right. Some of them have a little like teddy bear key that you plug into, that you'll have to plug into the monitor, use the same pads, but then you plug the teddy bear key in to indicate to the AED that it's a pediatric patient, and it'll dose down the electricity from there, okay? So we recommend using those on pediatric patients if you have them. If you don't, we'll take more electricity and go from there over not using it at all right? So what is our AED looking for, all right? It's looking for two different rhythms, all right? The two rhythms that the AED is going to shock are what's called ventricular fibrillation and ventricular tachycardia. We're going to talk about them here in just a minute, along with a couple others that go along with cardiac arrest, okay? So ventricular fibrillation is a disorganized cardiac rhythm that produces no pulse or cardiac output, okay? Basically what happens is it's just an unorganized, chaotic electrical activity that basically causes the heart to just kind of shake and quiver. Nothing actually contracts. It just all kind of shakes and quivers and goes all over the place, okay? We get nothing in terms of contraction or cardiac output, all right? It's associated with advanced coronary artery disease, all right? About 50 to 60% of cardiac arrests are in VFib during the first 8 minutes after becoming pulseless, all right? This responds very well to defibrillation. If we can catch it, that's where we want to get to a cardiac arrest, is in VFib, so that we can shock it and hopefully get it back, all right? So you can see here, the picture shows the kind of disorganized, chaotic electrical discharge of the ventricles, all right, which creates no contractility, so therefore nothing goes down. And just for your own gee-whiz, here's what it looks like on an EKG, all right? Notice there's nothing really going on there. The second one we're looking for is ventricular tachycardia, okay? So in this case, we actually have a organized rhythm, all right? It's coming from the ventricles, and it is moving at a very, very, very rapid pace, okay? So a rapid heart rhythm generated in the ventricles. The rapid rate reduces cardiac output, right? Because there is not sufficient time to fill the ventricle between the beats. So we're only filling just a little bit, therefore we can only squeeze a little bit. All right. If not corrected, this can often degenerate into VFib. All right. So if we want to correct this one. The fun part about ventricular tachycardia, all right, is that it can come either with a pulse or without a pulse. All right. Somebody can be in ventricular tachycardia and still maintain a pulse, right? As long as it doesn't go on for too long, depending on the speed, that kind of thing, age, how that patient's able to tolerate the pace of the rhythm. Okay.
I suffer with that.
Huh?
That's what I have.
You go into VTech? Sweet, we're gonna have to shock you while you're here.
I've got one built in.
Ah, nice. So if you go flying back in your seat and yell at me, I'm gonna know what it is, right?
Would they be conscious?
They can be, or they can be kind of a semi-conscious, depending on the severity.
So you hook up the AED to them, they would be conscious, and you'd be like,
I'm gonna hook my monitor to them and shock them in conscious state. Absolutely. The AED, we'll talk about the rules of the AED here in a little bit, and for that exact reason, we only put AEDs on unconscious people. So, and as a paramedic, yes, I'm gonna hook my box up and I'm gonna shock them and tell them this hurts. Hey, this is gonna hurt.
more than me.
If I have time, I try and sedate them, right? Give them a little bit of Versed, right? Knock them out a little bit. It's got a pretty nice amnesic effect to it, so they may not remember it. And if they're in dire straits and they're headed towards something and it's going really fast and they look like crap, they're going to get it without the Versed. Hey, this is going to hurt. You know, pow! They're usually not real happy with you, but it fixes the rhythm and they feel a lot better in the end, okay? So an AED responds to ventricular tachycardia when the rate is greater than 180. After 180, you're probably not going to be conscious anyway, so that's where it falls in, and they feel safe enough programming an AED to shock VTAC. Since someone in VTAC can be aware, the AED is applied only to unresponsive, pulseless, and apneic patients, right? So if you've got an unresponsive patient that's still got a pulse, you're not going to put the AED on them, so we kind of take shocking that responsive patient out of the picture for you. All right. So for unresponsive pulseless apneic, get an AED. Everybody else, no. So here's what ventricular tachycardia looks like. You'll notice the activity is organized, right? So each time we hit one of these peaks, that's kind of the indication of a beat there. So you can see that it's running at a very, very fast rate. All right. Ooh, too many. All right. If we don't catch ventricular fibrillation or ventricular tachycardia, all right, tachycardia can progress to ventricular fibrillation, and then we talked about fibrillation being the most common in cardiac arrest. If we don't catch it in time, right, it can then move on to what we call asystole, all right, which is our flat line, all right. There is zero electrical activity coming from the heart, so there is absolutely nothing to shock, okay. The chances of resuscitation from asystole are very, very much not good, okay. Defibrillation is not appropriate. And the reason we don't defibrillate asystole is because in ventricular tachycardia and in ventricular fibrillation, we've got a malfunctioning of the electrical system. Okay, it's there, it's working, it's just not working right. So basically, what we do with the defib, right, is we send a big jolt of electricity through the heart to kind of try and shock it, right? I know it's shocking, right? We try and shock it, right? And we give it this thump, and we try and knock everything out for a brief second, and hope then that when it restarts, the normal electrical pathways take over, okay? So we're just gonna give it this big thump, we're gonna knock it completely out for just a millisecond, and then hope that the natural takes over. Yes, ma'am?
Is it true that you can like punch a patient in the chest?
It's called the precordial thump, and yes, you can, right? It's the same thing, same principle, right? Give it a little bit of a shock from the not recommended at the not indicated at the BLS level. Okay, so yes, it's there, but don't do it.
I've seen it on like TV shows and stuff.
Yeah, you'll see it on TV shows. It's called the precordial thump. You got to do it appropriately in the right time and all that kind of stuff. But yes, you can. Same philosophy applies, right? Instead of using electricity, we're just going to literally thump you and hope that we kind of disrupt your heart for a brief second, and then the natural electrical process take over. So when we're in asystole, we have no electrical process to intervene in, so therefore defibrillation becomes not appropriate. You'll see medical shows all the time. Anybody who watches a medical show whatsoever, you'll see them shock asystole. It is a 100% inappropriate intervention that has pretty much no chance of ever working whatsoever in real life. Yes, sir?
How would they normally treat it?
Lots of CPR until we can hope to get ventricular fibrillation or some other performing rhythm back. At this point in time, in asystole, we're going to hope we can restore oxygen and glucose and hope that the heart starts something again. A lot of times we can work them back to fibrillation and then shock them and hopefully get a perfusing rhythm out of it. Chances are not good though.
Are you guys like doing like epinephrine at that point?
Yeah, on the ALS level, we're going to be doing that ALS level drugs. We're going to be looking for correctable causes. You know, there's going to be a lot of other stuff going on in the background, but at the BLS level, trying to get it to either something, you know, sometimes it'll just pop back out of asystole into something perfusing. A lot of times it'll go back to defib or something like that we can shock. Here's what it looks like. All right, I mentioned this one earlier, okay, pulseless electrical activity, okay? The electrical activity appears organized, okay? So when we look at it on an EKG, it looks like something's going on. Let me see, they don't put a picture in here apparently, sorry. So it'll look like a normal EKG, right? So a normal perfusing rhythm, but we will have no cardiac output, okay? Defibrillation is not appropriate in this patient because, again, the electrical system in this case, instead of asystole where it's not working at all, is actually working appropriately. There's just some other cause that's causing us that to then not generate a pulse. Could be a volume problem, could be an obstruction problem, right? There's lots of different things that can cause it, right? H's and T's, yay, right? Acidosis, trauma, toxicity, right? Glucose problems. There's a huge line. And that's when you're talking about doing epinephrine and stuff. If we're working a PEA arrest, okay, we're going to be doing a lot more things. We're going to be looking, because there's a lot of correctable things that we can bring somebody out of a PEA arrest with. So, so we are not going to defibrillate these folks. So some rules of the AED, all right? Nobody should touch the patient during AED rhythm analysis or shock delivery, okay? If you ever get admitted to the hospital and they make you wear an EKG, I'm going to let you in on a little secret that the nurses in the room are probably going to hate me for telling you. If you take one of the leads and you tap your finger on it rapidly around 150 or so times a minute, it's going to look a whole lot like VTAC on the monitor. It's going to set off alarms and lots of people are going to come running into your room. So if you push the button and they're ignoring you, very quickly on one, okay? For that exact reason, right, we don't touch a patient, okay? Because if we're touching a patient or moving them, it is very easy to represent ventricular fibrillation or, in some cases, ventricular tachycardia on the EKG just by moving somebody around, okay? So we want the AED to have the best chance at making an accurate diagnosis, so it's not sending electricity through somebody that doesn't need it, so therefore we don't touch anybody while we're analyzing, okay? And the AED will tell you. Also, we want to make sure we're not touching during shock delivery, okay? We all know about the conduction of electricity. It does move from person to person, all right? So if you are in contact with the patient or, you know, in the kind of touching them, then you will get the same electricity that they do. It will hurt. It will kind of take you to your knees a little bit, all right? You'll feel it for a couple of days, all right? I've never gotten shocked by, you know, never touched a patient during a defibrillation. When I first started, the old life packs had the paddles that slid into the top of it, because we could do the old Johnny Roy style paddles. They were really fun. But if you didn't get them pushed all the way back in, if you were using the pads, the button to push the shock was right up near the paddles, and it would arc over. So I went to shock a patient one time. We didn't have the paddle pushed all the way in, and it arced to my fingertip, and it took me about 3 or 4 days to feel my finger again. And it hurt like a son of a bitch. During medic school, we played with the pacing pads a little bit, you know, try to see who can take the most milliamps. And I can tell you that milliamps hurt, joules hurt a whole lot more. So definitely make sure you're clearing everybody away from your patient so that nobody gets shocked. AEDs can be used in patients of all ranges. Okay, we mentioned that earlier. Manual defibrillation is preferred for those less than 1 year of age because we go by how much they weigh and we dial it down quite significantly for those under 1 year. Okay. When we talked about the dose attenuating system, we prefer to use that in children under 8 years of age, okay? Or we kind of look at a child and go by size, right? Because we talked about how we've got some fairly big children out there, and we've got some smaller children as well. So if you don't know the age, or if you're thinking, man, that kid's like 7, but he looks like he's 10, cool, go with the fact that he looks like he's 10 and go with the bigger pads, all right? If you don't have, remember, see how it just says preferred, okay? If you don't have a dose attenuating system for children, we'll take a full shock, right? It's going to be, you know, it's not the most ideal, but we'd rather shock somebody that needs it than leave it alone just because we don't have little pads. Make sense? Okay. Here we have AED pads applied to a pediatric patient. All right. If you do have to use adult pads, right, surface area could become a little bit of an issue. Okay. There's a couple of different places we can place pads, right? What we call sternum apex is pretty much kind of a similar. So we put it up over the on the right side of the chest and then down kind of on the left side, which gives us a nice straight line for the electricity to travel through the heart. Okay. If space is at a premium, if you're having to use adult pads on a kid or something like that, you can do what we call anterior posterior. So over the left side on the front, roll them over, stick it on the left side on the back, and it'll just go straight front to back. In some cases, there are some studies out there that show that anterior posterior is actually a little bit better placement, but either one works. There's another one. So recognizing and treating cardiac arrest, okay? Scene size up in the primary assessment. If the patient appears unresponsive without signs or life, okay, instead of doing ABCs, we're going to go real quick and do a CAB, all right? These patients are going to be usually fairly obvious to you, okay? Somebody you're going to end up doing CPR on, you're going to walk in the door, your general impression from the door is going to tell you, hey, this person looks really bad, we're probably going to need to do, and we do the CAB, okay? We check for no longer than 10 seconds, all right? If the patient is apneic or has agonal respirations, we're going to begin CPR with the CAB approach, all right? So no pulse, no respirations, unresponsive, off we go for CPR. Push hard, push fast, don't stop, okay? So for patients less than 1 year of age, if their heart rate is greater than 60 with inadequate ventilation, we're going to assist or provide ventilations at 12 to 20 a minute, okay? So remember we talked about how all these CPR changes affected adults only. We really haven't changed much about the kids because the number one reason for cardiac arrest in kids is respiratory arrest, right? So we go back to the fact that kids haven't been alive long enough to have, coronary artery disease. They don't have heart attacks, right? Unless they've got something congenital, there's something else that has caused their heart to stop other than their heart, all right? So, and typically, and most commonly, it is some form of respiratory, all right? So, if the heart rate is greater than 60 and we've got inadequate ventilation, we're going to do ventilations for them, okay? That's kind of the standard. Inadequate ventilation gets ventilation. In kids, the 60 a minute becomes kind of an important milestone for us on our heart rate, okay? If it's over 60, that's enough to perfuse a child, okay? Anything under 60, okay, so if we have a heart rate under 60, or we have no pulse whatsoever, okay, so from 0 to 60 in a child less than 1 year of age, that's not going to be enough to get it done. You need to get on CPR and start doing it, okay? So if we've got inadequate breathing, we breathe for them. If our heart rate is above 60, we're cool with it. If it's below 60, we need to do CPR, all right? So if you check a pulse, it's 40, they're not breathing well, breathe for them, start CPR. We do 30 compressions to 2 ventilations for 1 person. We knock it down to 15 to 2 for 2 EMTs. So if you're with a partner, which you typically should be, 15 to 2 is your compression to ventilation ratio. Hopefully we all remember that from CPR class. Compression rate is at least 100 a minute, okay? You can get a little bit more out of that, great. Compression depth is 1/3 the anterior to posterior chest diameter, okay? So you can kind of picture about 1/3. And we want to make sure we ensure adequate airway ventilation and oxygenation, okay? Because chances are the reason we're doing CPR has something to do with the airway, so be very aggressive, opening, clearing, maintaining, ventilating, those kind of things. Apply the AED as soon as it is available, all right? And use a dose attenuating system if possible. For kids 1 year of age to 8 years, all right? If the rate is greater than 60 with inadequate ventilations, we're going to assist and provide ventilations just like we did before. If the heart rate is less than 60 with signs of poor perfusion or a pulse is absent, we're going to begin chest compressions. So less than 1, less than 60 is pretty much an absolute. Notice they added a few extra little caveats to this one, okay? If they're 1 to 8 and they're less than 60, you're going to start looking for some other signs of poor perfusion. SpO2, cyanosis, cool clammy skin, lethargy, altered mental status, all those kind of things. You find those, 60 ain't cutting it, start CPR, okay? If you've got any other signs that, if you've got a heart rate less than 60, but their breathing's fine, their SpO2 is great, their color looks good, they're awake, they're talking to you, 60's doing the trick, we'll note the fact that it's slow, but we'll leave it alone. Make sense? Okay? 30 to 2, 15 to 2, just like before, 100 a minute, 1/3. All right, those don't change. AED as soon as possible, dose attenuating if we can. Patients greater than 8, 30 to 2 compressions, 100 a minute, 2 inches on the depth. Most importantly, or more importantly, almost in the depth is also the recoil, okay? If you get tired and start leaning on your patient and you're not completely coming all the way back up off the chest every single time, I'm not talking about like lifting your hands, but you're not relieving the pressure each and every time, then we're going to start to increase the intrathoracic pressure, impede blood venous return, those kind of things, and we're going to start decreasing the effectiveness of our CPR. So rate, depth, recoil. Okay, you got to have all 3 of those to get good effective CPR. For an obviously pregnant patient, we're going to displace the uterus laterally. Okay, remember that whole switching them over to the left side just a smidge. Okay, so as we're working them, we kind of want to maybe put something underneath them to kind of tilt them just a little bit to one side or the other, preferably the left. Same reasons, right? Venous return, all those kind of things. Our secondary assessment, we want to try and obtain a history from bystanders or relatives, okay? But we're not going to interrupt chest compressions or delay defibrillation to do so, okay? If we've got people close that we can talk to while we're doing CPR and ventilations and defibbing and all that kind of stuff, we're going to talk to them. If not, we really don't care about the history until somebody else gets there to either take over so we can talk or go talk to the patient so we don't have to interrupt. Our resuscitation efforts take precedence over our history taking. Continue CPR and defib as indicated, okay? Once perfusion is restored, we're going to continue reassessment. We're going to go back and we're going to start ABCs, physical, head to toe, vital signs, those kind of things. Because at this point in time, chances are we haven't covered much more than our ABCs. Okay. If we have, great, we'll reassess it. If not, now's the time to get more of an assessment in. Okay. We want to make sure that we're checking pulses constantly and frequently. We leave the AED attached. Okay. So we leave it on and attached because it's going to continually be looking for those ventricular fibrillations and ventricular tachycardias. All right. Patients who are in cardiac arrest once have a very high tendency to go back into them several minutes after they come out of it. Sometimes it takes us 2 or 3 times to get them out of it to stay out of it. All right. So keep monitoring for that re-arrest. Keep the AED on. Right. Check pulses frequently. Those kind of things. If it can happen once, it can happen again. All right, after emergency care procedures and operating the AED, if ALS is not responding to the scene, here's your decision making for transporting, okay? If the patient regains a pulse, it's time to go, okay? We need to get him to the hospital and figure out why he was in cardiac arrest, hopefully provide some sort of intervention if we can, all right? Your protocol indicates transport after a prescribed number of shocks or no shock indicated messages, all right? Typically, if this protocol is in place, the number stands about 3. If you get 3 shocks in and you're still doing cardiac arrest, we're going to the hospital to find out why we can't get this person out of ventricular fibrillation. Sometimes they can go in and do some procedures or give interventions that can help, all right? We're starting to see some possibilities of, in these people that have VFib arrest, or let's say we had a STEMI patient, a heart attack patient that we saw the STEMI on before they went into arrest, with some of the mechanical compression devices and things like that. That perform very well. There's some talk of possibly taking these patients and doing cardiac catheterizations while they're still in arrest. So we would take them to the cath lab and let the mechanical device sit there and hammer their chest while the doc's in there trying to clear out the blockage and see if we can't reperfuse them and then get them out of cardiac arrest once they're reperfused. So your local protocol is going to dictate. All right. So typically it's after a number of shocks or no shocks, because at that point in time, you're going to take them to the hospital, and either you're in a PEA and we got to find the correctable causes, or you're in an asystole and we're probably going to terminate efforts at that point. All right. So transporting a patient who has regained their pulse and still has it. Okay, we're going to check airway, provide oxygen, ventilate breathing if breathing is inadequate. Okay, oftentimes it's going to take a little bit longer for breathing to come back than it is the cardiac function, so we're going to have to continue doing bag valve mask respirations. Have suction ready, all right? Vomiting is a very common thing when we're doing artificial ventilations and CPR. Transfer the patient to the ambulance. Consider ways of getting ACLS to the patient. So if you don't have ALS available immediately, and however you can get some form of ALS care to this patient, whether it's the hospital, an intercept, an aircraft, whatever you got to do, we want to try and get ALS to this patient as long as it doesn't delay our transportation. Always keep the AED attached. Do a secondary assessment. Check every 5 minutes. All right, for a full reassessment. For a pulse check, we're doing pulse checks every 30 seconds just to monitor and make sure that that person hasn't gone back into VFib. If the patient does not have a pulse and we're going to transport them, okay, we're going to continue to do CPR and defibrillation. We're going to follow our protocols. We're going to use extreme caution when defibrillating in the ambulance. Obviously, it's a much tighter, more confined space, so clearing of the patient is going to be a little bit more difficult. So we want to make sure that we do our due diligence and make sure everybody's clear. All right. Rendezvous with ALS as early as possible if it is a possibility. So some safety concerns. All right. Make sure everyone is clear of the patient before delivering the shock. We've covered that already. Do not defibrillate a patient who is lying in water or is wet. Okay. Water is an excellent conductor of electricity, and you don't want that electricity going anywhere but in your patient. Okay. So if they are wet, you want to quickly kind of towel dry them. You don't got to get them to the point where they're like super dry, but get most of the standing water off of them. Remove them from a wet puddle, those kind of things. Use caution when defibrillating on metal surfaces. Again, conduction of electricity. All right. So if you are doing it on a metal surface, make sure that not only is nobody touching the patient, but then also nobody is touching that metal surface as well, because the electricity could have a tendency to conduct through those. Remove any. What's that?
Bumpy
Bumpy roads can be a concern. Obviously, when you're in the back of the truck, that's part of one of the hazards of trying to clear a patient when you're defibrillating in the back of the truck. We want to remove any transdermal medication patches to the chest. Okay, we don't want to fuse these to the patient by running a whole lot of heat and electricity through them. All right. If the chest wall is covered with hair, it will reduce the effectiveness of the shock. All right. So if you've got a fairly hairy individual, this not only goes for placement of the pads during AED, but also if you're assisting the paramedic with putting the EKG on. All right. When we're dealing with the AED pads or the monitor pads, okay, you've got a couple of different options. You can either use the electrodes or a razor to remove the hair. All right. So if you've got 2 sets of pads, you get the first one on, rub it in there real good, rip it off in a very expeditious fashion. That'll clear out quite a bit of the hair. Get the second set out, stick it back on. Now you've got a better contact. Or in a lot of cases, you carry razors. All right, we have a razor, a little disposable razor in the back of our each monitor that we can, kind of make somebody into a little bit of a man o' lantern if we have to. All right, but the waxing method with the electrodes actually works really, really well, and it's really fast. Right, you just get it on there, rub it up real fast, maybe get a little bit of friction into it and some heat, and then off it comes as fast as you can. You can usually make yourself a pretty good surface. AED maintenance. Okay, scheduled maintenance is critical. Make sure you replace batteries when you're supposed to. All right. Allow the machine to perform a self-check at the beginning of every shift. So when you come on as part of your truck checkout, you'll turn it on, you'll let it kind of run through its process, and then when it starts giving you directions, that's when you know it's all functioning appropriately. You can turn it back off. Okay. Always have extra batteries available because you never quite know, and it's kind of embarrassing to have to call for somebody else to come bring you a battery like I did on Wednesday. So refresh and maintain your skills through continuing education. Make sure you review each incident to make sure everything worked appropriately, that your protocol functioned, everybody followed protocol. Maintain knowledge of protocols. AEDs are under the authority of medical direction, okay? So each AED that's placed anywhere in public on an ambulance has to have some form of medical direction governing it, okay? So in a lot of cases, like if we had one, if you worked at a business and you had an AED hanging on the wall, somewhere, someplace, somebody's medical director put his name on the fact that that AED could hang there. All right. Oftentimes, it either comes from the manufacturer or in Travis County, we have a registration process through the Office of the Medical Director where you call and say, hey, we got an AED, and they come out and they check the location of it and they talk to you about who's trained to use it, all those kind of things. They get its location programmed into CAD, and then that falls under the medical direction. But you can't just go out, if you go out and just purchase a home use AED, somewhere, someplace, there's a medical director's signature on your ability to use that AED, okay? So it's not always apparent to you, all right? But every AED has to have medical direction.
Those things kind of run for.
So
we got to cut down the.
Yeah, they're way down from what they were when they first came out. They were up in like the 5 to 6 range. Depending on what features and what accessories you wanted to buy. Now they're closer to about 1,000, 1,500, depending on what you get with it.
You get medical insurance to pay for this thing? Like my parents are both freaking heart cases, so.
That would be a really excellent question. I'm not 100% sure. I know home use is still pretty low when it comes to AEDs. When I was in Arizona, I taught AED training for their CPR program and their AED program. They actually got a manufacturer that had a really cool program. So like if I worked for company A and we bought an AED, if we bought one and donated it to somebody else, then the company would match it. So you'd actually donate 2. So that was kind of a cool program. And then we'd come out and do the training for it. There was a bunch of us that did it. And I remember we went to one of the school districts. I think it was the state required that the athletic trainer have one, right? So that anytime a sporting event was going on campus, it needed to either be at the event or somebody had to have it, readily accessible, that kind of thing. But then the district, they had a student. It was a high school district. Had a student that had a pretty severe heart condition, enough to where she actually carried an AED in her backpack with her everywhere she went. She never went anywhere without an AED. And so they actually did have an incident on campus with her. She, so her friend pulled out the AED, shocked her, and, she was fine. But then the school district kind of decided, hey, maybe we should. And so they decided that every school was going to have every single one of their staff members was going to have training. They offered a couple of the kids to go off with it for like one of their like National Honor Society projects or something like that. And we trained literally every teacher in the school district. I went to the school board meeting and trained the school board. I trained probably at least 100 kids. And it was really cool that they took off with it. And then the district went and just bought and just saturated their campuses with AEDs. There's 2 or 3 of them on every campus. So it was kind of a really cool thing. So that's one of the few instances where I've seen, somebody that actually had one outside of just like the public access ones. Most of the time, if you need like an AED or something like that, you'll get the internal one like Emma has, where it's just.
Before I had my surgery, they offered me an AED vest to wear. I was like, no way.
That sounds like a stylish proposition.
Yeah.
Bedazzle it, do whatever.
Yes, sir.
British flag. So, if you're talking about the CAD system, registering your AED with the CAD, so if a call goes into 911 for somebody in cardiac arrest at Walmart, every 911 operator would know that and would say, start CPR and send somebody to go get the AED, which is located in something.
Yeah, anytime, and it's not just cardiac arrest. So like, if a building is registered to have, let's say we had one here at the Avery building, right? And it was programmed in at this address. Anytime any call would come in at this address, the first thing that CAD would auto-populate. So as soon as the dispatcher entered the address and like went to the next step, the first call comment that would come up for them would be AED is located second floor next to, right? And it has pretty specific instructions to the point where even like if, let's say this building here didn't have one, right? And there's one registered at the hospital, it'll even pull addresses within it'll pull AEDs within a certain distance as well. So oftentimes we'll see a call and it'll say AED is located at this address, and then it'll give the location of the AED. So like if it's in the building next door, it'll pull it and prompt the dispatcher to send somebody to go get it next door. In some cases, there's even some areas, I think I mentioned this when we were talking about some of the stuff before, there's some new apps out there that they're putting out to where you can go and register, you download the app and register yourself as a certified provider, CPR and all that kind of stuff. And then the app programming ties into the CAD system. And it'll actually, if your GPS identifies you, like say cardiac arrest dropped over at the nursing building and I had the app, my app would start going crazy and say, hey, there's a cardiac arrest call, within so much of a distance from you, and then I could know to go over and do CPR. So a lot of cool things coming with those. All right, cool. So talking real quick about the energy levels. All right, electrical current is measured in joules. All right, biphasic defibrillators use lower energy settings and they get a little bit more effective energy delivery. All right, follow your protocols and manufacturer guidelines for energy levels. Typically, when we're talking about automated or AEDs, right, you don't have a say in the energy level other than plugging and unplugging the pediatric stuff for the dose attenuating system. And even then, all you're doing is just identifying adult versus pediatric. The monitor itself is actually determining the joule levels, all right? When you start to get into the manual defibrillators like we carry on the ambulance, then we can start picking our own joule settings. Cardiac pacemakers, okay? Just because somebody has a pacemaker or an implanted cardiac device, right? So every once in a while they don't work. If your patient is in cardiac arrest, it means that particular device is no longer working. So your concern over doing any damage to it should be next to none, if not none at all, okay? So the only thing that we tell you not to do is don't put the pad right over top of it, because that's going to cause a whole lot of impedance to that energy as it's trying to deliver, okay? So we want to move it. Most manufacturers say about an inch away. So your pad placement needs to be about an inch away from any implanted device, all right? But don't let it deter you, because obviously if you're there doing CPR, the machine is not working. Pacemakers can be found, let me go back here real quick. Pacemakers and defibrillators, after a certain year, and I don't remember when it was, I think it was somewhere like around the 80s, at first they were just kind of putting them whichever side of the chest the doctor really kind of felt like. Now they've become pretty uniformed over to the left side. So in an adult, it's going to be the left, kind of the left upper chest. In children, all right, notice they can be other places, all right? I'm not exactly sure where his is. I think it's down here. but you notice his scars up here, all right? So just because they're children doesn't mean they can't have pacemakers and defibrillation devices, so make sure you're looking for them on all patients. Automatic implanted cardioverter defibrillators detect rhythm disturbances and deliver shocks, okay? We don't place the AED pads over the ICD. If the ICD is operating, allow 30 to 60 seconds for it to complete its cycle before we do the AED, okay? How are you gonna know if this is operating? Your patient's gonna kind of be jumping around, and if they're awake, they're not gonna be real happy with their device, right? Has yours hit you?
Mhm.
You haven't had yours hit you yet?
It's charged up a bit now.
It's
Rude awakening.
it's moderately uncomfortable from what I understand, right? I've been on a few people, and all of a sudden the guys are just sitting there and be like, ah, like, and just scream and jump, and right, and that's it hitting it. So if you do notice that it is firing, like it says, allow about 30 to 60 seconds before you put your AED on and start your business there. So chest compression, the automated chest compression devices, we have a mechanical piston device, a load distributing band or vest, and we also have an impedance threshold device. These are things that are helping us with CPR, okay? This is the Lucas 2. It's a chest compression system that actively compresses and decompresses the thorax, all right? So we've got this large piston here, right? This will extend down to however big the patient is, all right? This little white piece on the end is a large suction cup that attaches to their sternum, the sternal area of their chest. And then pneumatically, the new ones, which that one is, I believe, are battery operated. The older versions ran off of an SCBA tank. They were really loud and fun. They're like, ka-chung, 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 and it uses pneumatic to push the chest down. And then when it recoils, the suction cup engages and pulls the chest up, right? And they operate at a preset rate. So they are pretty, they make doing extended cardiac arrest pretty easy. However, we've proven with some of our CPR feedback data that a good solid manual compressor with the help of a metronome and a mechanical device, we can put the data up next to each other and you can tell me which one was which. So although they're cool, we can still do just as good a job manually if we pay attention to what we're doing, so we don't rush to get these on, because oftentimes they take a little bit of time and they can cause a delay in CPR. Here's what it looks like in progress. We also have what's called the auto pulse, okay? When this first came out, they affectionately nicknamed it the geezer squeezer, all right? Because it's a giant band that wraps around the patient and it kind of constricts the entire chest as opposed to just using that one piston device, right? Depending on who you talk to somebody from Zoll, they'll tell you the auto pulse does better. You talk to somebody from Lucas, they'll tell you Lucas does better. You know, I only have any real life application experience with Lucas. I saw a presentation from the auto pulse people, but then I watched my medical director tear them apart pretty hardcore. So I don't know, never actually used it in person. This is what's called an impedance threshold device, or the brand name that it's holding here is the Rescue Pod. They were the first people to bring it out. Basically what the Rescue Pod does is it goes on top of either the back valve mask or the, what's the word I'm looking for? The endotracheal tube, right, that we place to breathe through. And what it does is it only allows air to come in when specific pressures are applied, okay? So when we do chest compressions, right, we compress the chest, and when we recoil, we want all that negative pressure to pull blood, because we really don't care about air at that point, because we're going to shove it in with the back valve mask the next time the little light blinks, okay? So what the impedance threshold device does, if we didn't have it and we shove down and we let go, we're going to get blood and air, and for every bit of air that we get that comes back into the lungs, decreases the amount of blood that we can get back. So basically what the impedance threshold device does is it cuts off that just kind of natural return of air down through the tube when we recoil on a chest compression. It'll still allow air to flow when used as a bag valve mask, right? When we create enough of an air pressure behind it, it'll allow air to go down. But it doesn't just allow that general seeping of air, and it keeps the interthoracic pressure pulling venous return, okay? It's also got little red lights on it that tell you when to breathe, so you can keep your respiratory rate where it's supposed to be as opposed to hyperventilating. And that, my friends, is chapter 15. All right, so any questions on any of that? Cool, go ahead, and it is 12:15, come back at 1:15, and we will finish up our, we'll do chapter